teaching program for postgraduates in pathology. Today we have a slide seminar on a very interesting topic given by ma'am. It's on of shoes and ships and sealing wax. And the faculty that will be taking up the seminar today is Dr. Anita Borges ma'am. And as we all know, she's lab director and consultant pathologist at Center for Oncopathology, Tata Trust, Mumbai. We have 5 students who will be participating in this slide seminar. I would request all the students to kindly introduce themselves one by one. We'll start with Dr. Adil. So the first student we have is Dr. Adil Aziz Khan. He's a third year PG student from VMMC and Safdarjung Hospital, New Delhi. Then we have Dr. Annapurna Reshwari, who is a third year PG student at Bangalore Medical College and Research Institute, Bangalore. We have Dr. Sai Ranjani. She is again a third year PG from Andhra Medical College, Visakhapatnam. We have Dr. Subodh Kumar Sahu, again a third year PG at Nalanda Medical College, Patna. And lastly, Dr. Krutina Parekh, third year PG at AMC MET Medical College, Ahmedabad. So, any attendees who have any queries related to the slide seminar, they can put up the questions in the chat box, and we'll take up the questions with the ma'am at the end of the seminar. The moderators for today's session are Dr. Parsh Singh, Assistant Professor Pathology at Institute of Medical Sciences, Lucknow, and myself, Dr. Poonam Sharma, Assistant Professor, Department of Pathology, AIIMS, Jammu. The webinar hosts are Dr. Anita Borges ma'am and Dr. Sumit Gujral sir. A few reminders. In case of any connection interruption, low or no sound, video freezing, video lag, kindly leave the meeting and rejoin with the same link. And in case there are any questions, you can type them in the chat box. And do not send requests for annotation to the presenters. These are a few disclaimers. A few more disclaimers. Brief about the upcoming talks. Next week on Tuesday, that is 4th October, we'll be beginning with the breast pathology with normal histology and grossing of breast by Dr. Ayushi Sahai, professor at TMH Mumbai. And on Thursday, 6th October, we have a slide seminar on breast, benign lesions of breast by Dr. Varsha Shah, consultant histopathologist, Department of Pathology at Royal Gwent Hospital, UK. So with this, we begin the seminar. Over to you, ma'am, for the session now.
Thank you so much, Poonam. Let's see if I can start my... Okay. Let me just make it full screen. Is it full screen now for everybody?
Yes, ma'am.
Yeah, okay. All right. Now you've all seen this, the title of this slide seminar, which is of shoes and ships and sealing wax. Okay, was anybody curious about this shoes and ships and sealing wax? Yeah?
Yes, ma'am.
Okay. Is that Annapurna?
Yes, ma'am.
Were you curious about this title?
Yes, ma'am. I was curious. Like all of your slide seminar have a unique name and some meaning to it. Until we attend the class, we won't get to know what it is.
All right. So now tell me, trying to find out what is this thing of shoes and ships and sealing wax? Did you? No? Okay, let me ask Adil. Adil, you wanted to attend the slide seminar, right? Did you try and find out what is this, the meaning of this title or where it comes from?
It comes from the poem written by the Lewis Carroll.
Yes,
It
loudly so that everybody can hear.
uh, this is it comes from the poem written by Lewis Carroll, the Walrus and the Carpenter, in which in the poem there is a line of shoes and ships and sealing wax. When they are talking, both Walrus and Carpenter are talking to each other and discussing about the beach where they are present, and they are just there's a general talk going on in between them.
Absolutely, yes. And there you see the walrus, okay, and a walrus has got a mustache. It really does. If you've ever seen a walrus in, pictures, I've never seen a live walrus, but if you see pictures of a walrus, they have this mustache, and people who have that kind of very bushy mustache are that kind of mustache is called the walrus mustache because they look like this, the kind of hair that the walrus has just above its two tusks. A walrus has got tusks like an elephant. Okay, and Lewis Carroll was very good at making up all kinds of characters. And this is the walrus, and you can see the carpenter, and you can see that the carpenter has got a bag next to him, in which there is a saw and some of his tools. Anyway, they were walking down, and they were hungry, and they wanted to make a meal of some sort, and they saw the oysters. Okay, and oysters, for those who have eaten oysters, is a very very tasty dish, and I hope you know what oysters are. They are kind of shellfish. Okay, so they were wondering how they could lure these oysters so that they could get them all together and make a meal of them. Okay, and so they started talking to the oysters. And this is the poem. And the poem says, now on the left, and I was hoping that we would have Alice. Alice was the sixth student who was supposed to be here, but she isn't there. Because this is a poem that is being written by Lewis Carroll in his very two really wonderful books. If you haven't read Alice in Wonderland and Through the Looking Glass, then you've missed something. It's a very very interesting books to read. And this little girl Alice was the daughter of the dean of the Oxford College where Lewis Carroll was a teacher, and he used to entertain Alice and her sister by telling them all kinds of stories. And these collected stories are in these two books called Alice in Wonderland and Through the Looking Glass. Now, what does it mean of shoes and ships and sealing wax? Actually, it means, it's a collection of nothing in particular. It is miscellaneous. Okay, so now the walrus says to the carpenter, the time has come, the walrus said, to talk of many things, of shoes and ships and sealing wax and cabbages and kings, and why the sea is boiling hot and whether pigs have wings. So it is complete nonsense. Okay, but it is a way of the walrus and the carpenter had this poem so that they could lure these oysters. And there you are, you see the walrus and the carpenter talking to the oysters. And they so mesmerized these oysters, and to mesmerize means they so uh, got the oysters so engrossed in their stories that the oysters didn't realize that one by one they were being eaten up until there were no oysters left at all. Okay, now that is not the purpose of my talk. The purpose of my talk is not to have all these five students for dinner. Okay, I've already had part of my dinner, and I'll probably have some more later. So I don't really want to have them for dinner, although a lot of students think I eat them for breakfast. It's not true. It's just that we are going to see. It's not like this slide seminar has a theme. It has no theme. It's not GI or bone or soft tissues or anything else. It's just cases that have been picked up at random, and therefore it is of shoes and ships and sealing wax And all the other things that I mentioned here, there is nothing connecting each of these things to each other. So it is absolutely miscellaneous. Right. So now let us get on to our. Why is it not moving? I don't know why my slide. Ah, there. Okay, it's moved. All right. Now I know that I gave four slides, and we were on. You could look at them. All of you could look at them, and also the attendees could do. They were on Telegram, but I thought I would start with something that none of you has seen. Okay, and Adil, you were very keen, right, to attend one of these slide seminars. So would you like to take this spot case, please, Adil?
Yes, ma'am. 70-year-old male with dysphagia, copious mucus and occasional blood in stools. An endoscopy revealed an ulcerated polypoid mass on the anterior wall of the rectum.
Okay, very good. So now Adil, I'll show you the sections, and you describe them, and then come to a conclusion. Okay? Let's
Yes,
start. Come on.
Uh, the HNE stained section showing two bits of the polypoidal mass, which ulcerated polypoidal mass. The lining epithelium in one of the bit is not there, which is in the right side, and on the left bit there is some small partial lining is there of, I guess, columnar epithelium can be appreciated. Some, and in between uh, and there is crypts are there, which are a bit dilated, slightly like hyperplastic, filled with mucus, and the stroma is fibrocollagenous tissue. In this power, I can appreciate this.
Okay. Does everybody agree? I mean, out of now Adil has done this. There are other four of you over there. So, is Subodh there? Subodh, can you hear me? Can you see the screen? Are you there, Subodh? Is Subodh available, or has he not been able to join? All right, let's go to Ranjani. Ranjani, do you agree with everything that that Adil said of what is being seen on the screen?
Yes, ma'am.
You agree. Is there anything more or less that you want to add or subtract? Yes?
No, I agree.
All right. Very good. If you have nothing, then say nothing. Yeah, Kritina,
Yes, ma'am.
yeah, you agree with what Adil said?
Yes, ma'am. Yes, ma'am. Agree.
You agree absolutely with Adil said, with what Adil said, right?
Yes, ma'am. Right.
You know what Adil said? Can you repeat what Adil said? You were paying attention, right?
Yes.
Yeah, so tell me, what did Adil say?
Smear show the two bit of tissue. On the right side, there is no epithelial lining, and on the left side, there is an epithelium, mostly columnar epithelium. The crypts are seen, and mucus filling glands are polypoidal mass.
I see. Okay. He didn't quite say that, but anyway, more or less what he said. What about you, Annapurna?
Ma'am, in the right side bit, we can see some muscle fibers.
You can see some muscle fibers.
This,
Very nice. So would you ask for annotation, please?
yes, ma'am.
Yes. Do you know how to ask for annotation?
Yes, ma'am.
Yes. Okay. So now,
Ma'am, I have sent the request.
no, I haven't received the request. You press on that. Can you?
Yes, ma'am, I'm pressing The annotation symbol.
Ah, now it's come. Okay, very good. I've approved it. Come on. So now can you use any color that you want? And you said that you could see some muscle fibers, right? Again, okay, I'm approving again. But it's already approved, Annapurna. Come on. Are you not,
No, ma'am, I'm not able to mark the.
sorry, you're
I'll
not able
request.
to mark?
Yes, ma'am.
Okay.
I'll request again, ma'am.
Wait, I'll have to start. Yes, start again now.
No, ma'am, it's not coming. In the right side tissue with.
All right, let me find out whether you are. Is this
Yes,
what
ma'am,
you
it has
mean?
come. Yeah, this.
Is this what you mean?
Yes, ma'am.
Yes, exactly. All
No.
right.
Yes, ma'am.
Adil, did you see that those? Did you see this very pink-looking?
Yes, ma'am. I can appreciate now.
Now you
Yes.
can appreciate.
Yes, ma'am.
Yes, it's there.
Yes.
Okay. All right. So, what do you think, Adil, are these muscle fibers? First of all, what kind of muscle is it, Adil?
Ma'am, like it is a polyp. Clinically, it is a polyp in the, I guess, rectal wall. So,
So, what
the,
muscle do you think it is? You think this is the rectum, right, Adil? You didn't mention it, um, nor did Kutina, because she gave a little bit of a description, but nobody mentioned that it was the rectum. So it is a rectum, yes.
yes, ma'am.
Yeah. So why is it the rectum, Adil?
Ma'am, the crypts have like numerous goblet cells are there, and in rectum the number of goblet cells are comparatively more as compared to rest of the rectum.
Excellent, very good. And so now here everybody can see, yeah, that there is, you can see this marked area, right? And the
Yes,
marked area shows you what extremely pink, um, very elongated cells. And so they must be muscle cells like what Annapurna said, right? You agree, no, Adil?
yes, ma'am.
So what are those muscle cells? First of all, are they skeletal or smooth?
Smooth muscles.
Smooth muscle cells. So what muscle, from what what muscle layer of the rectum are they? Huh?
Uh,
Which
one
muscle layer of the rectum do these smooth muscles come from?
maybe the biopsy, the tissue which is present here, like mucosa, submucosa, and then
No. I'm asking you what this muscle represents, okay?
okay.
And you say it has come from the tissue. Of course, it's come from the tissue, and we
Then,
have
ma'am,
established that
the
this is the rectum.
the mucosal layer, the muscle present
What's
in
it
the mucosa.
called? What is that muscle called? Is this, can anybody help him out
Mus
over here? Yes, Krutina, what is this muscle?
muscularis.
Muscularis propria.
Muscularis mucosa.
Propria.
Oh, muscularis what?
Mucosa.
Muscularis mucosae. Yes. So you're seeing a portion of the muscularis mucosae over here, all right? And so you've got the rectum, you've got crypts, yes? And I think what you mentioned, Adil, was that some of the crypts are dilated. Is that all you can say about the crypts?
Uh,
Adil,
they are not
crypts are
only
dilated?
they are dilated, and their shape is also, the architecture of the crypts is a bit distorted, like few,
So the architecture is distorted,
and
very good.
also
Huh?
like in one of the crypt I can say ki might be there is branching or something like.
All right, so they may be branching. Adil, if you want to try and ask for annotation, see if you
Yes,
can do
ma'am.
it.
I have
There you
given.
are. All right, come on, now show me. Where do you find the branching? Can you move your? All right, yes. So there is something that looks like branching.
Also in this script, maybe
Yes, so so the crypts are distorted. Very good. They are branched. Okay. Now you have had, I don't know if all of you attended because some of you said that you didn't have the opportunity to attend all. And Adil, did you attend the talk on gastrointestinal mucosal biopsies that were you able to attend? That Dr. Siddhartha Datta Gupta took? Did you
no,
attend that?
no, ma'am.
No. Did anybody here attend the talk by Dr. Siddharth Datta Gupta? And then there were other people who also did gastrointestinal um, biopsies, including Dr. Vikram from the United States. So when you look at a gastrointestinal um, biopsy, and in this case, we're looking at the large.
My internet issues are in the main server.
Who is speaking?
When I hear no, sir, like
Who is this who's
whatever ma'am
speaking?
is telling, I'm not able to hear properly.
Who? Who is this? Who
Oh,
says that? Annapurna, you can't hear properly. What are you saying?
no,
Because you were talking while Adil was talking. Okay, all right. Adil did not attend, but maybe somebody else attended. Did Krutina? Did you attend
No, ma'am.
Dr. Siddhartha Dattagupta's
No,
talk?
ma'am.
You
No,
did.
ma'am, I did not.
Dr.
No.
Ranjani?
No, ma'am.
No. Uh, Annapurna? Did you? Did you attend? Well, she can't hear me, it looks like. And what about Subodh? Is Subodh there?
Uh,
Is Subodh there? I don't think he's there either. So we've only got three people now for most of this thing who can actually answer. Well, uh, I'm sure that all of you are third years, right? So now at least you should know that if you are looking at a colon, yes, a mucosal biopsy of the colon, what are the things that you ought to be able to say about this mucosal biopsy? And there is a system that everybody follows. So now would you like to tell me, Adil, what system you follow?
like the epithelium, crypts and villi should be maintained in their position, and the crypts should be not like this, but what we are seeing in this
So
case.
now, Adil, you're telling me what normal looks like. I'm asking you for a system. So what do? Do you start with looking at the epithelium?
Yes,
Then
ma'am.
you look at the
At the
crypts.
crypts,
Then you look at what?
uh, in the crypts, we will also look for the cells like
So you look at the crypts, fine. So you look
in
at the
crypts
superficial epithelium, you look at the crypts, then you look at what else?
in
Besides the crypts, then we'll come to what you look at in the
submucous,
crypts. But epithelium, crypts, then what?
then in the submucosa.
Submucosa. So in a mucosa, you see submucosa, Adil.
No, ma'am. In mucosa, I will look for the crypts and the cells present in the crypt.
I see. So Adil looks at epithelium, superficial epithelium, and Adil looks at the crypts. All right, Krutina, what do you look at?
Ma'am, first epithelium, then
Yes,
crypts,
yes.
then submucosal glands.
Mucosal glands. This is the rectum, okay? And I'm talking about rectum. And where
Okay,
do
ma'am.
you get submucosal glands? Krutina, forget about
Ma'am.
whether it's the rectum.
No, ma'am.
Let's even take the stomach. Do you get submucosal glands in the stomach?
Duodenum.
Huh?
Duodenum.
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 Duodenum. So then what submucosal glands are you talking about, Krutina? Huh? So now forget submucosal glands. So you have said the same thing that Adil said. You will look at the epithelium, you will look at the crypts. What else do you look for in the mucosa?
Lamina propria.
Sorry? Yes,
Lamina
Adil?
propria. Lamina propria.
Ah, you look at the lamina propria. Okay. Third thing. Then what do you look at?
Then the muscularis mucosa.
Then the
Muscularis.
muscularis mucosae. So now we have come to an understanding of how we actually examine this any mucosal biopsy from the gastrointestinal tract. Okay, mucosa is what is being biopsied. So we look at the epithelium. Very good. And Adil, what do you find about the epithelium over here?
The epithelium is ulcerated mostly, only
It's denuded, right?
denuded, yes, ma'am, and only small portion is showing some
Excellent.
remnant lining.
That's number one. Now tell me, what have you noticed about the crypts?
Usually the crypt should be looks like shows similar type of morphology. All the crypts more
What
or
is
less in
that
the
type of
same.
morphology, Adil? What
Um,
crypts like in the large bowel?
uh,
They're long tubular
a long
glands, the
tubular,
bottom
yes,
of which is called a crypt, right?
yes, ma'am.
So the glands of the large bowel are long and tubular,
Tubular.
right? They are tubular glands. Do you know that, Adil?
Yes, ma'am.
They are. Okay. Adil, there is some free space over here, right? Between
Yes,
these two things. Can you ask to annotate, please? And I want you to draw the very good. Come on now. Now come on. Draw a diagrammatic view of how the crypts look like. When I'm saying crypts and you're saying crypts, what we mean is the tubular glands of the rectum or the large bowel. Come on, draw it. Yes,
they are like parallel test tube arrangement,
exactly. So come on, yes. Very good. Next. Very good.
and the glands are
No,
arranged
no,
like.
go on doing
Okay. Yes,
at the
ma'am.
glands. They're not glands. They are cells, okay?
Yes.
They're secreting cells. Those are goblet cells. So, yes. Now, everybody has seen what he has drawn. I assume, Adil, that you are saying that this is the surface epithelium, right?
Yes, ma'am.
All right, very good. Does everybody agree? Now, let me ask Annapurna. Has he drawn this accurately?
The epithelium, like villi, will be there in the.
There should be villi. Where? In the rectum? There should be villi in the rectum?
No, the crypt in rectum there will be crypts only. Only the
There will be
villi.
only glands, tubular glands, right? So we're talking about rectum. So I'm asking you now, has he drawn this accurately? Annapurna, is this accurate? Annapurna is not there. All right. Let's ask Krutina. Is this accurate?
Yes, ma'am.
Accurate. Okay. What about you, Ranjani?
Yes, ma'am.
It is. Well, I don't think it is accurate, not because he's a bad artist, okay, and I wasn't expecting him to be, a bad artist, okay, but Adil, do you see space between each of these glands, tubular glands? Should there be a space between the tubular glands?
No, ma'am. I have drawn like this, but it should be in a more close proximity,
It should
and
be more close. They should touch one another
and
with
also
no
I
space
have.
in between, right?
Yes,
There's
ma'am.
something that you have neglected to draw. And what is that? What is that, Adil, that you have neglected to draw? What have you neglected to draw?
The epithe
Huh?
the
No.
epithelium.
Where should the bottom of these glands, which we should call the crypt, where should the crypts lie?
Um, just in the muscularis mucosa.
It should touch
The
the
muscularis.
muscularis mucosae, right? Yes or no?
Yes, ma'am.
Now, can you draw that?
No, ma'am.
You didn't draw it, but can you draw it now?
Yes, ma'am.
Shall we go? Ah, there you are. So each of these glands, which are long and tubular, and they should be of the same size, they should be approximated to each other, which means they abut one another, and they should lie with their crypts, that is, the deepest portion of the gland should lie on the muscularis mucosae. Now, Adil, okay?
Yes, ma'am.
You have drawn this. Now, please tell me how you will describe the crypts that you see in this picture over here.
In this picture, the crypts are of variable size,
Yes.
and the architecture is distorted, and some of the crypts showing branching also,
Very good.
and some are a bit dilated as compared to other, so not maintaining the tubular structure. The
Well, it may be
test tube
maintaining
like
the tubular structure, Adil, but this
sorry,
is an
not
oblique
maintaining,
cut. Okay, so
not
you don't
maintaining.
know. But at
Yes,
least on the left-hand side picture, you can see a nice epithelium on top. And
and
as far as possible, we believe that this is a perpendicularly placed
yes.
section. Okay, so now tell me, what is wrong over there with the crypts? We have described how crypts should be. Yes, long, tubular, no space between them. Correct?
Yes, ma'am.
And that their crypts, the crypt should lie, or the deepest portion should lie on the muscularis mucosae. Now tell me, what's happened on the left-hand side?
The crypts are
What?
shortened,
Of course, they're not only shortened,
and they are
they're irregular, and
irregular.
their crypts have been lost, haven't they been? Look
Yes,
at, they should be all one next to the other, close to one another, etc. Even if you see them cut obliquely, you will see all the circles or the oval shapes when it is obliquely cut should be absolutely next to one another without any space in between. But it isn't so, right? So crypts have been lost. When we say crypts, the glands have been lost. Okay, so you can see that they are distorted, they are lost, they are shortened. That's what you're seeing in both these sections over here. Very good. So now you talked about what's happening with the crypts. Do you think there is loss of mucin in the crypts? Because that's the other thing that we have to see. Do you think that there's loss of mucin, Adil?
ma'am, mucin is, I guess, present in many of the crypts.
Mucin is present in many of the crypts. Okay.
Some of them, in some of the crypts, only I can see कि they are less. Otherwise, the mucin is present in all of the crypts.
Okay, so for all practical purposes, mucin is more or less present in whatever crypts that there are. You see goblet cells are seen. You're not seeing what we normally call loss of mucin and what we call regeneration. And Annapurna pointed out, unfortunately, she's disappeared, and I can't raise her on the. If she's there, she will say, yes, I'm here. But she's not here, and she pointed out something very interesting. She pointed out that there was this area here. You can see this area. Yeah, and it goes here too. You can see the same pink cells over here, all over here, and that's part of the muscularis mucosae. Now, it's quite possible over here that the muscularis mucosae has been transversely or obliquely cut, and therefore it looks irregularly placed in this mucosa. It is not the nice line that one sees in the normal muscularis in the normal mucosa. Agreed, Adil?
Yes, ma'am.
All right, good. Now, let's go to the next slide. What do you see here now? Can you see that muscularis mucosae
Yes, ma'am.
much better?
Yes, ma'am.
Yes,
Yes,
Yeah,
ma'am.
ma'am.
and very good. But you never told me anything about the lamina propria. So we said we should see epithelium, we should see crypts, we should see,
Uh, yes, ma'am.
yes, the lamina
In
propria. Now what is this normal lamina propria? Is this abnormal lamina propria? Come on, Adi. We can't go on forever. And this is a spot quiz.
Ma'am, there are some, in this power, I can only say some inflammatory cells are there in the lamina propria, but I cannot
You
appreciate.
can't appreciate anything else. Very good. Krutina, what do you want to say about the lamina propria?
Ma'am, I can't appreciate properly.
You can't appreciate anything. Okay. Ranjani,
Same with me, ma'am. I too can't
oh, you
appreciate anything.
can't. You appreciate nothing about this lamina propria. I feel very sorry for you. What is the normal lamina propria of the rectal mucosa like?
Ma'am,
Yes, tell me. If you
in
had to describe the lamina propria of the rectum, or for that matter, the colon, or the small intestine, or the stomach, what does the lamina propria, how would you describe it?
it should be lymphocyte rich intraepithelial. Lymphocytes are there in the
Lymphocyte rich. That is what the lamina propria should be. Normal lamina propria. Yes, Krutina, you agree with Adil?
Yes, ma'am.
Yes, ma'am. Oh, and what about Ranjani?
I think in the colon and the rectum, there will not be anything like lymphocyte rich in the lamina propria.
Do you know what the connective tissue looks like, Adil, in the lamina propria? What should it look like? Any lamina propria that you see in the gastrointestinal tract, uh, I'm not talking about the esophagus because it doesn't have a lamina. Yes, all the way from the stomach to the rectum. What is that lamina propria like? Poonam, is anybody answering in the chat box what
loose
lamina
con-
propria
Loose
should be?
connective
Yes,
tissue.
please tell me so that
Loose
Adil,
connective
etc.,
tissue.
can be prompted. What are they saying about the lamina propria?
Yes, ma'am.
It
Dr.
has
Didi has
loose
answered
connective
loose
tissue.
connective tissue, uh,
Loose connective tissue. All right. Anybody else?
glands and loose connective tissue. Many are answering loose connective tissue.
Absolutely. There is what they call loose areolar tissue. No, it is absolutely loose connective tissue. Now, please tell me, Adil, is this lamina propria? And you see it both on the right and on the left. Is this loose connective tissue?
no, ma'am.
Oh, so
No,
it's
no.
not. So what is it then, Adil? What has happened to the loose connective tissue?
Maybe some fib fibrocollagenous tissue can be there. There is something with there.
It
I
has
cannot.
become fibrous. So there is fibrosis of the lamina propria. And this is something that you should be able to appreciate. And that's why it is so important to know what normal structures look like. And this is the rectum, okay? And what you must have a picture in your head as to how a normal rectum looks like. And those who were answering in the chat box were absolutely spot on. The lamina propria, whether it is in the stomach or in the small intestine or in the rectum, is loose. Okay, you see it that there is a kind of transparency to this lamina propria. There is loose areolar tissue. This is absolutely opaque. It's opaque. Why? Because it is fibrotic. And not only is it fibrotic, but you are seeing the fibers of the muscularis mucosae, which
Exposed.
Annapurna very correctly identified. The fibers of the muscularis propria are actually running in between. Can you see them running in between the crypts? Here you can see them down here, but there they are. Look at these fibers. They are all intermingling with the crypts, and it's everywhere. You can see right up to, in not only in this area, but in many areas you see that there is fibrosis and there is the muscularis mucosae is splaying. The meaning of the word to splay is to fan out. So they are fanning out into this lamina propria and they are present between the crypts. Do you appreciate that now, Adil?
Yes, ma'am.
So there you are. If you can see my cursor, you can see that these things are
Panning. Yes, ma'am.
all in between this. So that's another very important observation that has to be made. So we talked about the crypts. You can see the branch crypts. You can see the distorted crypts. You can see the space between the crypts, which means that there is loss of crypts, and you're seeing the splaying of the muscularis mucosae. Now you can see it better at high power.
Yes.
Adil,
Yes, ma'am.
can
Yes, ma'am.
everybody see it now?
Yes, ma'am.
Yes, ma'am.
Yes.
Yes, ma'am.
Excellent. Very, very good. All right. You can see it even better over here. Loss of crypts, fibrosis of the lamina propria, the loose areolar nature of this lamina propria is gone. And of course, here there are some inflammatory cells. But you guys were not paying attention to the quality of the lamina propria. You were only interested in looking at whether or not there were inflammatory cells. Yes? So now, Adil, look at this. There is so much to see and to observe apart from, oh, I can see this and I can see inflammatory cells. Do you appreciate the fibrosis of the lamina propria now, Adil?
Yes, ma'am.
Yes, you do. Do all of you do?
Yes, ma'am.
Excellent. Has Annapurna joined again?
Yes, ma'am.
You have joined. Very good, Annapurna. Do you now appreciate your smooth muscle and how it's
Playing out.
it
Yes,
is
ma'am.
ramifying between these crypts and
Yes.
yeah, and the tubular glands. Has Subodh come back? Subodh, are you there? I think he's having difficulties.
Not yet.
Okay, so we have 4 people. Now that we have made all these observations, what is the diagnosis? Start with Adil and then we'll go to the others. Chalo.
Ma'am, it could be a solitary ulcer.
Solitary rectal ulcer.
Ulcers,
Very
yeah.
good. What do you think, Prutina?
Ma'am, solitary rectal ulcer.
Solitary rectal ulcer. All right. What about Annapurna?
A solitary rectal ulcer, ma'am.
Excellent. And Ranjini?
Solitary rectal ulcer, ma'am.
Very good. So, you know, this is just a way of analyzing this whole thing. What was the most crucial decision that had to be made? All right. This appeared to be polypoidal on endoscopy. It looks distorted, okay, on histology. And many people might make a diagnosis because they see the lamina propria and they appear to, these glands appear to be infiltrating the lamina propria, may make a diagnosis of neoplasia. But this is not neoplasia, okay? This is non-neoplastic. Now, whenever you are looking at any lesion, this is one of the schemas that you could use to try and make a diagnosis if you are not sure what is happening. Okay, otherwise we look at the thing, we make observations, and like in this case, I think once we had the right observations, the diagnosis was not difficult. Okay, so otherwise we ask congenital or acquired. If it is acquired, is it physiological or is it pathological? If it is pathological, then we come to the next question. Is it neoplastic or non-neoplastic? In this case, we have come to the conclusion there is nothing that looks neoplastic over here. It is non-neoplastic, right? So now do you see those, I think 7 things over there? Adil, which will you pick from these 7 things? What is the pathological non-neoplastic process that is occurring in this case?
the changes in the lamina propria, how the muscularis,
So pick, no, pick from this. You've got cell. You know what these
okay,
these
yes, ma'am.
7 things are? Have you ever seen these 7 things before? Anywhere? Adil,
Yes,
Krutika,
ma'am.
Annapurna, Ranjani, where have you seen these 7 titles?
General
General
pathology.
pathology.
General pathology.
In general pathology,
Pathology.
right. So if it is non-neoplastic, if it is neoplastic, then it goes into neoplasia, which is to the right of this algorithm. Okay, so these are the general pathology chapters. So now Adil, pick which general pathology chapter does our case represent? Is it metabolic disease?
No, ma'am.
No.
Um,
It is not disease of the immune system. It is not environmental and nutritional diseases. It is not metabolic disease, right?
yes,
Yeah.
ma'am.
So now you have 4 things to choose from, Adil. So which one are you going to choose?
Ma'am,
What?
repair, regeneration, healing, and
Healing and
fibrosis.
fibrosis. Anybody has any other thing to choose? No. So that's what it is, right? Repair, regeneration, healing, and fibrosis. Now, why did this injury occur? That's one of the things that we have to ask, right? So the diagnosis is, you said solitary rectal ulcer. Now we know that solitary rectal ulcer is actually it is the result of mucosal prolapse syndrome of the rectum. Anybody in the chat box saying anything, Poonam?
Ma'am, they were also answering repair and regeneration.
Excellent, very good. So everybody's got the hang of it, and this is a mucosal prolapse syndrome. Now, what is mucosal prolapse syndrome, Adil?
Uh, Ma'am, when the uh,
Anybody? Well,
abnormal function of the anal and pelvic sphincters will will lead
correct.
to a prolapse. That is,
Yes. So this is the cause of the injury is chronic ischemia resulting from pinching of the chronically prolapsed mucosa. Why? Because there is incoordinate sphincteric action of the puborectalis. That's the external sphincter. Okay? So when the peristaltic wave reaches the external sphincter or the puborectalis, it is supposed to relax. But there is incoordinate action and the puborectalis does not relax. As a result of which, that peristaltic wave is hitting that roadblock, so to speak, and the only thing that is movable over there is the mucosa. No, none of the other structures in the rectal wall can actually move, okay? And therefore, that mucosa keeps prolapsing, and it is prolapsing through a tight sphincter, which is almost like a noose around the neck of this prolapsed mucosa, as a result of which there is always some ischemia of the mucosa because the blood supply gets temporarily disconnected, as a result of which you have ischemia of the superficial portions of the mucosa. And all of what you're seeing, disordered architecture of the glands, because these are regenerating epithelia and they never regenerate very in the way that they should, architecturally regenerating, fibrosis of the lamina propria, and you have this splaying of the muscularis mucosa. Now, if you think about it, this disordered architecture, yes, is seen in many inflammatory conditions of the bowel. Yeah, it's seen in ulcerative colitis. It's seen in Crohn's disease. It is nothing but a regenerating phenomenon where the normal architecture of the bowel, once it is disturbed, large bowel, does not get back to entirely normal. But there is one thing, Adil, that you don't see in ulcerative colitis, which you see in this reparative condition. What is that? You may see all this gaps, you may see loss of mucin, you may see branching, distortion, shortening, etc. But what is it that you don't see in ulcerative colitis, which you're seeing over here?
The fibrosis of the lamina.
Absolutely. In ulcerative colitis, you may see it in Crohn's disease, but you don't see it in ulcerative colitis, and that is fibrosis of the lamina propria. All right. Are there any questions about this? I think we've done that, and we can now come to the first case that was circulated.
No, ma'am, there are no questions.
No questions in the chat box?
No,
Any
ma'am.
questions amongst you four over here? Because I think we have lost Subodh for good. Okay, that's good. Next. Now, who wants to take the next one? Annapurna, will you take this?
Yes, ma'am.
All right, come on.
26 years old male with complaints of chronic abdominal pain for approximately 6 months. On examination, a vague lump felt in the upper abdomen. On upper GI exam, an upper GI endoscopic examination and endoscopy guided ultrasound were performed, followed by CT scan.
All right, come on now.
The endoscopy guided ultrasound revealed multiple submucosal nodules in the stomach, which were aspirated under US guidance. In this picture, ma'am, the cells are arranged in a loosely cohesive cluster. There is some amount of new overcrowding is there in a proteinaceous background.
All right. Is that all that you want to say about this? How the cells are clustered in a proteinaceous background. There's nothing else that you want to say about this?
Some are scattered also, ma'am, few cells, and the cells are plasmacytoid.
Cells are plasmacytoid.
Plasmacytoid.
Okay, that's all you want to say?
Yes, ma'am. In this picture.
All right, good. Let me ask the others. Is there anything that they would like to say? Krutina?
Yes, ma'am.
That's all you want to say? There's nothing else that you guys want to say? That the cells are loosely cohesive, that she said that they were plasmacytoid, there's a proteinaceous background, and some cells are scattered. All right.
Ma'am, there is overcrowding of the cells.
All right, overcrowding. Very good. Ranjani?
Yes, ma'am.
That's all.
Yes, ma'am.
What, Adil? Nothing?
Ma'am, like we can also describe the morphology a bit. Like all the cells are monotonous.
Very good. Yes.
And
Minimal
they have a minimal or
all monotonous looking. Excellent. Yes, Adil. Come on. Let's all together help one another and come to some description.
So discohesive,
yes.
discohesive cluster and singly scattered, having monotonous population of cells with a wispy cytoplasm, plasmacytoid, giving a plasmacytoid appearance with minimal or no atypia in this.
Yes, so they are monotonous. There is minimal or no atypia. You don't want to even say anything about the nuclei? What cell only has got wispy cytoplasm and looks plasmacytoid? There's nothing about. You realize that this is cytology?
Yes, ma'am.
The nucleus get away without describing things in histology. You won't get away if I am there, but certainly in cytology you won't get away without describing the cytoplasm and the nuclei.
Yes, ma'am.
So now, Adil, you're on it. No, Annapurna didn't think it was worth describing the nuclei. Now you tell her what kind of nuclei there are.
In the next slide, the nucleus.
Oh, but you can't see the nuclei here?
No, ma'am. The nuclear features are better appreciated in the
Better appreciated. Okay.
next
So
slide.
now
So I
tell me,
thought,
what do you see here? Come on, Adil.
So the nucleus is round to
Absolutely round, yes.
and having a homogeneous bland chromatin with
Excellent, yes.
and in this
inconspicuous.
power we cannot comment on nucleolus.
You can't, okay. But it has a defined, you can see that defined nuclear membrane. Can you or can you not?
Yes, ma'am.
Yes, ma'am.
There is a defined nuclear membrane. It is, they are round, yes, of course, and there is a bland chromatin. In fact, you can hardly see anything in this as far as chromatin is concerned, right? Excellent. Oh, very good. So we have had a cooperative effort. Okay, now come on, Annapurna.
Ma'am, in this, the cells are arranged in a loosely cohesive and discohesive clusters,
Yes.
and the cells show minimal pleomorphism. There is the cells show clear, moderate amount of clear cytoplasm, and
Clear. What is clear about it?
ma'am, there is minimal pleomorphism.
No, no, no. What is clear about the cytoplasm? You said the cytoplasm was clear. Do you
Pale,
really think the cytoplasm is clear?
pale, ma'am. And
Oh,
if it is
pale. Pale is different from clear.
a pale, moderate cytoplasm, ma'am.
Ah, all right. Then,
There is the cells are plasmacytoid. Nuclear. There is minimal pleomorphism. The nucleus is round to oval in shape with regular nuclear membrane and bland chromatin. And a few of the cells show grooving, ma'am.
so there is some clefting or
So,
grooving in some of the
some
cells.
of the
Yes.
cells.
Yeah, and if you look carefully, maybe you see
Some,
something that looks like a tiny little nucleolus, or
yes,
maybe it
ma'am.
is a
In this,
chromocentre or something of that sort, right?
yes,
Most
ma'am.
of the cells are in flat sheets. Yes?
Yes,
Yes,
ma'am.
Annapurna, you want to annotate? Come on.
Yes, ma'am. I
Most of them
thought,
are loosely cohesive in flat sheets. There is some degree of overlapping. Yes.
yes, ma'am. And I thought this could be inclusion, like
So
groove.
you thought there was a nucleolus?
Yes,
Maybe.
ma'am.
I don't know.
Maybe.
There are other areas also that
Mm,
seem to have some nucleolus or something over there.
yes, ma'am. This
Fair
is
enough. Okay. So now we have seen this, that these are in flat sheets. There are also cords. You can see the cord-like structure. Yes. There you can see this cord-like structure, and then cells that are cohesive, loosely cohesive, and some of them are overlapping. Excellent. Now come on, Annapurna. You can see the singly scattered cells. Yeah.
the singly scattered plasmacytoid cells having pale, moderate cytoplasm and bland-looking regular nucleus. Ma'am, I thought these are these intranuclear inclusions could be.
Intranuclear inclusions.
Ma'am, these.
I don't think so, no? What is more likely is, what is more likely that you have a defined nuclear
Nucleus
membrane.
membrane.
Isn't that right?
Yes,
Yes.
ma'am.
And these are all Giemsa stained slides, and not one of you mentioned that these were Giemsa stained slides. Okay, so they have a grayish pale cytoplasm. Can you see that? It's very gray, no?
Yes, ma'am.
Grayish amphiphilic, if you wish, cytoplasm. And you're right, they're round or they are oval. If you cut this nucleus transversely, you will see that it is round. Okay, and you did see a few, sort of grooves in one or two, but you're not seeing them in this particular slide. All right, now what is this stain, Annapurna?
Pap stained, ma'am.
The PAP stain. All right, so now what are you seeing over here?
Ma'am, again, plasmacytoid cells and few inflammatory cells, ma'am, neutrophils.
Few inflammatory cells.
Yes,
What
ma'am.
are those inflammatory cells, Baba? Please?
Neutrophils.
Neutrophils. So are they inflammatory? Every time I see an inflammatory, a neutrophil, does that mean that there is inflammation?
No.
No. So where have these neutrophils come from, Annapurna?
It could be from the blood-derived cells also, ma'am.
Yeah, obviously they're from the blood, right? Yeah, they're from the blood. This is there are so few um, neutrophils over here that you're not going to talk about this being inflammatory. I hope all of you agree, and you will not talk about inflammatory cells. It really frustrates me when I hear people talk about inflammatory cells. All right, Annapurna, what do you think?
Ma'am, for this I couldn't come to any conclusion, ma'am.
You couldn't come to a conclusion, but at least you have to try, right? Yeah, are any of us here trying to make one diagnosis? No, this has come to us on our in our routine cytology reporting, and we have to try and make some kind of sense, right? So how do we do that? How do we try to make sense of what we are seeing? You have now described it. So describe this all in two sentences. Can you describe it in two sentences? Come on, Annapurna. The smears show what?
The smears show the
Yes,
loosely cohesive or discohesive monotonous population of plasmacytoid cells with
oval nuclei. Yes.
round to oval nucleus with moderate amphiphilic cytoplasm, moderate pale cytoplasm.
And what is the character of the nucleus? It's bland and
Bland.
homogeneous, right? Can you see anything in that nucleus? Is it vesicular? No.
No,
So it's
ma'am.
a non-vesicular,
Non-vesicular.
bland,
Bland
sort of moderately dense nucleus. Isn't
with
that what
overcrowding.
we are seeing? So now what do you think it fits into? Yeah, see, I put all the observations down. Medium-sized cells, singly scattered and in loose aggregates, monomorphic. They are well-defined cytoplasm, eccentrically placed. That's why we keep saying plasmacytoid,
Cytoplasm.
plasmacytoid. Bland, uniform nuclei. There are some grooves present, but there are no mitoses, right?
Yes, ma'am.
No. So mitoses are not seen. Very good.
No
So now, if
nucleoli.
you've made these observations, what do you think your thoughts should be? How do you start to approach this? Come on, Annapurna, what do you know about this? You know that it is, tell me what you know, never mind what you can speculate about. What are the things you know about apart from these observations? What do you know? Do you know anything about this? Anybody? What do you know? Do you know that this is a lesion in the stomach and it is a submucous lesion?
Submucosal.
Now, isn't that interesting? It is not a mucosal lesion. It is a submucosal lesion. And this is a submucosal lesion that has all of these observations that we have written down on the left. Okay? So if this is the thing, what are the possible submucosal lesions that could have this morphology? Come on, Annapurna, it's not difficult.
Just
Come on.
could it be just
What could it be?
just gastrointestinal stromal tumors?
Now you know something else. It has epithelioid morphology,
Morphology.
right? Excellent. It has a plasmacytoid appearance. See, these are all the things that we know, and these are interpretations that we are making from these observations. So it's epithelioid morphology. It has a plasmacytoid appearance. However, the nuclei are not stippled. Okay, they are not showing you that salt and pepper appearance, nor does it show you the classic plasmacytoid wedge, the little cartwheel-like appearance. And you can know that this appears to be benign, or at least
A low grade.
low grade. Isn't that something that you can make some kind of interpretation from, Annapurna? Excellent. See,
Yes, ma'am.
you are able to do this. If only thing is that we have to get into the whole sort of, we have to know what we know, And most of the time, we're just bothered about what is the diagnosis, what is the diagnosis. Okay, so what are the possibilities now? Okay, just submucosal tumors. There's submucosal lesion, then it must be a tumor, right? It's unlikely to be something that's inflammatory. So now let's see what the people in the chat box say, and come on, Annapurna, which would be your last choice from these possibilities? Plasmacytoid tumors can be neuroendocrine. You mentioned epithelioid smooth muscle tumor because that is a submucosal tumor. There is something in the stomach which is called a plexiform fibrohistiocytic tumor. Yes.
My last option will be
Plasmacytoma and gastrointestinal stromal tumor. Now, which is your last choice, Annapurna?
neuroendocrine tumor, ma'am.
You don't think it's a neuroendocrine tumor. All right.
It is my last option, ma'am.
That is your last option. All right. Come on, Kruti now.
Ma'am, GIST, last option.
Last option is GIST. Right. Ranjani?
Epithelioid type of GIST, ma'am, my last option.
Epithelioid type of GIST. That means you don't think it is, right? That's what you're meaning? Or this is your first option? What?
Last choice.
Last
Neuroendocrine.
choice. Okay, very good. And Adil?
Ma'am, plasmacytoma could be the last one.
Plasmacytoma. What's going on in the chat box, Poonam? Or
Ma'am,
Pansha?
neuroendocrine tumor.
Last option, neuroendocrine tumor, okay?
A few have answered plasmacytoma and one has answered GIST.
GIST. Okay, my last option is a plasmacytoma. Okay, why? Because do you think that plasma cells have got a light gray cytoplasm like that? Huh? What should the nuclear characteristics of a plasmacytoma be?
Cartwheel.
Cartwheel appearance of the nucleus.
Cartwheel. It is a dense nucleus, no? Which is broken up into a cartwheel-like appearance. So I would say plasmacytoma. I don't really think that it is a neuroendocrine tumor, but you know, once in a way, neuroendocrine tumors can fool you, all right. But I don't think that anybody should pick the choice of plasmacytoma, although I don't know how long we've been hearing plasmacytoid, plasmacytoid, plasmacytoid. But I would not pick a plasmacytoma. Okay. Now, which would be your first choice then? Come on, Annapurna, what's your first choice?
GIST, ma'am.
GIST. Okay, very good. Let's ask Adil, which is your first choice?
Ma'am, GIST. I will.
GIST. Okay. Krutina.
Ma'am, GIST.
GIST. Okay. Ranjani.
GIST, ma'am.
GIST. All right.
Ma'am, and all
Anybody? What's in the chat box?
GIST is the response from many.
GIST is the response from many. All right. The choice of the person who sent this to us was neuroendocrine tumor because of the plasmacytoid appearance and the fact that there were multiple nodules in the stomach on endoscopy. Okay. Anyway, this patient had a CT scan. Now here is the CT scan and you see this tumor which is large. Okay. And there were multiple nodules as well as this one large tumor in the stomach wall. Excellent. So somebody put in a needle. You can see the needle over here in the bottom picture. There's the needle tract and it is gone into this tumor. And here is the tumor. Come on, Annapurna. What do you see? What do you see over here?
Ma'am, there are two photomicrographs.
Yes.
In one, there are tumor cells. The lower magnification of the left side picture is lower magnification. In lower magnification, we can see the tumor cells.
Yes.
And some fibrous tissue.
Does it look, Annapurna, just like what you saw in the smears?
Ma'am, the higher magnification looks like the...
Yeah, and then what about the lower magnification? Doesn't look like what you saw in the smears? Of course it looks like. They're loosely cohesive, epithelioid looking cells or with a plasmacytoid
Cytoid
appearance.
appearance.
It looks exactly like that, and it's got this. You can see the cytoplasm. We saw it in the Giemsa, and we saw it in a PAP. But in an H&E, you can see that this cytoplasm is not amphiphilic, nor is it grayish. What is it? It's pink,
Eosinophilic.
extraordinarily pink.
Pink.
Okay, so this has an epithelioid appearance. It's got this plasmacytoid eccentrically placed nucleus. Okay, and some of the cells have got an elongated appearance. You see that? And I don't think that this is just a crushing or a whatever artifact. You can see that in this little group that is present over here. Okay,
Spindling.
right. So what is the diagnosis now? We made our observations, and if you look at it, except for saying that there is an eosinophilic, well-defined eosinophilic cytoplasm, we have not changed our description from what we saw in the smears. Yeah, there is a very important point that I'm trying to make. Okay, everybody buys books. Yeah, you all buy books. Annapurna and Adil and Krutina and Ranjani, you all buy books? Yes?
Yes, ma'am.
Right. Do you buy cytology? Have any of you buy cytology textbooks? Have you bought? Or you?
Yes, ma'am.
Oh,
Yes.
yes. So who has
Yes, ma'am.
bought? All of you have bought?
Yes, ma'am.
Yes, ma'am.
Now I have some advice for you. Okay. Cytology textbook is expensive, right? How much does it cost? Anyone can tell me?
8K, ma'am. 8,000.
8,000 bucks. Yes. So, I used to tell people that you should burn your cytology textbooks, because if you have them, you consult them all the time. Yes?
Yes,
And
ma'am.
it is not a good idea to consult your cytology textbooks, because we all know how histology looks, and we should be using our mental faculties to extrapolate from histology to cytology, and from cytology back to histopathology. There is nothing that is so different about cytology. And if we don't do that, we are like, human beings who have lost their corpus callosum. Yeah, right brain, left brain. Left brain is histology, right brain is cytology, and there's no corpus callosum. And that's why we read textbooks of histology and textbooks of cytology. And what have we learned over here? That there is really no difference. The histopathology has given rise to exactly the same appearances in cytology. Yes or no?
Yes, ma'am.
Yes, ma'am.
Yes. So now, you can't burn the book. You spent 8,000 bucks on it. So what do you think you should do? You should...
Correlate.
Oh no, I don't think you should go to the book at all. You should take that book, find some place, and lock it up in a deep, dark cupboard and throw away the key. Yes, because otherwise you'll be tempted to go and look at it. So what you should do is, every time you have histology, think, how will this look like if it is aspirated? Whether it's a breast tumor or a thyroid tumor or a lymph node which has got TB or a salivary gland or any other thing. All right, every time you're looking at histopathology, mark my words, you just close your eyes and think, if I put a needle into this lesion, how will it aspirate? And every time you think that, when you see an aspirate, you think backwards and say, I wonder how this will look like in histopathology. And since you have been doing this exercise all the time, histopathology to cytopathology, you have no problems going the other way. Okay? Fine. Now, so now we have our observations. We know what is the broad category of lesion over here that you would want to put it into. Hmm? Come on, Annapurna, what would you choose? Epithelioid, mesenchymal, hematolymphoid, small blue cell, or can't say? Whenever I get a tumor, I try to put it into one of these categories. Whether it is cytology or histopathology, it doesn't matter. I like to think what is the pattern of this tumor. So come on.
Mesenchymal, ma'am, in
You
this
would put
category.
it mesenchymal if you saw this histology. Excellent. Somebody else? Come on, Krutina.
Ma'am, epithelioid,
You would put it as epithelioid.
epithelioid.
What would you put it as? Adil, you've disappeared?
No, ma'am. Ma'am, epithelioid.
Epithelioid. I see people saying, which means they can't choose between epithelioid and mesenchymal, right? Yeah, okay. Ranjani,
Epithelioid.
you'll choose epithelioid. And who's left now? Everybody's had their chance? Yes. So
Ma'am,
the
and the
trouble is
attendees also have answered epithelioid.
epithelioid. Okay. I think that everybody knows it is not hematolymphoid and it is not small blue cell, right?
Yes, ma'am.
Yes. So you know that. You know it's not hematolymphoid, it's not small blue cell. But you are having problems with epithelioid mesenchymal, and therefore you say, maybe I can't say. Some people want to say epithelioid, but at the same time, in the bottom of their hearts, they feel, it could be mesenchymal. I know that Adil had this problem because he thought about it for some time. Others were saying epithelioid, and Annapurna said mesenchymal. Okay? Very good. So this is the choice if somebody had to say. What was in the chat box, Poonam?
An epithelioid.
Epithelioid. Okay, very good. So broad category of lesion, I think we had two main things, epithelioid and mesenchymal. So now we have to go and find out what it actually is. No, so we have to do some immunohistochemistry. And what immunohistochemistry do we need to do for anything that's epithelioid? Yeah, we do cytokeratin, EMA.
Yes.
Somebody thought neuroendocrine, so maybe synaptophysin and
Synaptophysin,
chromogranin.
chromogranin,
Yes. And then if it's
mesenchymal,
mesenchymal, there are four things that we always do and we should never neglect to do. Smooth muscle actin, desmin, S100 protein, CD34. And because it is the stomach, we need to do secret and dogwood. Okay? So cytokeratin and EMA are negative, no synaptophysin and no chromogranin. So now what do you think will come positive? Annapurna? What will come positive?
ma'am, SMA.
SMA, all right. Anything else? SMA will come positive. All right, come on. She said SMA. Krutina?
Ma'am, dog 1 or CD117.
Dog 1 or CD117. Ranjani?
Dog 1 or CD117.
All right, and Adil?
Um,
What will come positive?
and maybe dog 1 and CD117 only.
So there you are. CD117, dog 1, this was an older case. We did CD34, it doesn't matter. You don't need to do dog 1 if you've got CD117 that's positive. So what is the diagnosis, Annapurna? What is it?
Gist.
It's a gist.
Gist.
It is not the standard spindle cell gist, right? It is
It's
an epithelioid gastrointestinal stromal tumor. Okay, now the diagnosis was the least important part of this whole story. No, it is about how do you approach a diagnosis. Okay, when you have a tumor, you must try to put that tumor into some of these patterns. Does it look epithelioid? Does it look mesenchymal? Does it look like small blue cell? Does it look hematolymphoid? These are the four major categories that we think of when we see a tumor. Okay, and that's the way we can then, if we don't know at once what it is, we can start to make a differential diagnosis and put our immunohistochemistry markers accordingly. Okay, now this is also what you should have taken from this particular case is that you don't need to consult textbooks to learn the the pictures that these tumors make and just match pictures. You have all come, or most of you come to cytology from first having done histopathology. There are very, very few students who do cytology before they come to histopathology. I feel a little sorry for them. But those who come to cytology from histopathology, you are allowing your faculties of extrapolation and observation to atrophy if you go and consult your cytology books straight away. Did you get the point at all? Yes, did you?
Yes, ma'am.
Yes, and you should try to use your faculties of extrapolation to actually do this on a regular basis. And you'll see how easy it is, therefore, because there is no difference when you match the two pictures. Okay? Excellent. Very good. Now let's see, are we going to the next case? Yes. Who's going to take the next case now? Huh? Let's ask Krutina. Krutina, will you take this?
Yes, ma'am.
Chalo.
42-year female, total thyroidectomy. The growth showed a multinodular goiter with a small 2 centimeter gray white nodule with irregular edges, section of the nodule.
Okay, come on. I know it isn't the best picture in the world, but I think it's a good case. Come on.
The smear show uneven size of thyroid follicles, which is filled with a colloid-like consistency. Uh, there is higher cellular areas. Show the
Yes, so at this part, what do you see? You
yes,
see a very cellular area, right?
yes, ma'am.
Yes,
High cellular
excellent.
area.
Okay. Do you know, Krutina, because you haven't attended too many talks, that's what you said. Do you know what the purpose of a low power examination is? Why do we do a low power examination? Is this a low power, Krutina?
Yes, ma'am. It is a low
Excellent. So
power.
why do we need to do a low power examination? After all, examining, cells at high power is so informative. No, you see the cell size, you see the cell shape, you see the cell nuclei. What can you see here? Hardly anything.
Cellularity.
So why do
We
we
can
need to do a low power examination?
to see the cellularity.
To see cellularity. Acha. Okay. That's why you do a low power examination to see cellularity, Krutina?
No, ma'am. And architecture of the
All right. So you see cellularity, you see architecture. Is it? You do low power examination? Acha, let's ask somebody else. Ranjani, why do you do a low power examination?
We need to see what structure we have received and
Yes.
the architecture of the cells and what is the predominant morphology seen.
Predominant morphology seen. Okay, that's an advance over whatever Krutina said. So let's ask Adil. Why do you do a low power examination, Adil?
Apart from the architecture and the normal tissue, uh, the to look the abnormality at the low power, so that we can further confirm it to compare with the normal. We can compare easily with the
Okay.
normal part.
All right. You said more or less what the others have said. Annapurna?
Ma'am, as the others told, if, to look for the native tissue, whether we received any native tissue or not. and to compare the normal means
Yes.
architecture, and to differentiate, ma'am, whether there is any different architecture is
Yeah,
there, and
sure.
to look at where to focus, to decide where to focus
Where to
the.
focus, yes. So you have done an overall scan of this thing, and then you want to see where you should focus your high power. Very good. That's all very well said. Okay. But there is another very important reason why we look at low power. Yes, we look to see if there is normal tissue. Yeah. And that is very important, because if today you know that, say somebody tells me that this is from the breast and actually it has been taken from some other part of the body, yes, and I just neglect to see whether it is really from the breast or not, and I make a diagnosis of adenocarcinoma, but it is not from the breast, it's from somewhere else, okay? Because I never bothered to notice whether there was any normal uh, tissue that has been included. Whatever it is, you need to know whether there is any normal tissue. In other words, you have to ask yourself a question. Yeah, is there any normal tissue? And the reasons I've told you. It really focuses your attention on whatever is normal, and if that normal is not what you expect, then of course you have to go find out where the block or the slide or whatever it is has been switched. Okay, so is there any normal tissue? The second thing is there any abnormal tissue? Do you think that everything that comes to us is abnormal? Do you think? Is it
No,
possible
ma'am.
that sometimes people have biopsied normal or have missed the normal tissue and missed the abnormal tissue and biopsied normal tissue? It's quite possible, right? So in which case you have to say that it is unremarkable. So I don't think that every case actually has abnormal tissue. So the second question you ask yourself at low power is there any abnormal tissue? And somebody in the chat box said very clearly and rightly that the third question you ask yourself is, what is the relationship between the normal and the abnormal? In other words, is this tissue that you are seeing, the abnormal tissue, how is it related to the normal? If I have skin, is this lesion in arising or damaging dermis, or is it of normal origin? Yes, that is the meaning of relationship. There is a tissue, there is epithelium, or there is mucosa, there is lamina propria, there is deep tissues. And in the first case, we saw that this was, sorry, in the second case, we saw that this was something that was in the submucosa. Okay. So all of these things are important. So what is the relationship between the normal and the abnormal? The fourth thing is the pattern, which all of you very rightly said that you have to ask, what is the pattern? And number 5 is what Annapurna said, where should I start my high power examination? Okay. You can use the system or not use it, as the case may be. But I found that it is very useful. It has become second nature to me now. All right. So when I'm looking at something, I am asking these questions in my head. It's not coming up as a conscious thought anymore, but because I've done it so many times, a red flag goes up when one of these questions is not answered the way that it should be answered. Okay. I'm sure that there are people in the chat box who are answering this, because every time I take a slide seminar, I emphasize the ways in which we can systematize our diagnostic approach, and then it becomes second nature to us. And all I tell you is, you may have a diagnostic approach which is different from mine, but whatever it is, please have a diagnostic approach and systematize it so that you are not higgledy-piggledy going all over the place, trying in each case a different system. Or that you want to use. Okay, very good. So now tell me, Prutina,
Yes, ma'am.
if you use this system, what will you say? Is there any normal tissue, Prutina?
Yes, ma'am. Thyroid.
There is thyroid. All
Thyroid.
right. Is there any abnormal tissue? What is the answer? Yes or no, Prutina?
Yes,
Is
ma'am.
there any abnormal tissue?
Yes, ma'am.
Oh, yes. Very good. What is the relationship of the normal to the abnormal? Come on. What is the
Uh,
relationship?
Ma'am, there is no boundary between normal thyroid follicles and
Yes.
higher cellularity.
Excellent. So it looks as if there is a mingling of the thyroid and this abnormal tissue, right? There is abnormal tissue. You can see it. It's very cellular. You said so. Yes. And although it seems to be relatively circumscribed at one part, there is no clear distinction between the thyroid and this abnormality. Does everybody agree?
Yes, ma'am.
Yes, very good. Okay, what is the fourth thing that you're supposed to answer, Tina? Question? We have done normal tissue. Is there abnormal tissue? Yes. What is the relationship? Yes. Now what? What's the fourth question? You have to ask yourself. Anybody
That
else ask her? Yes? What's the fourth question, Adil?
The architecture
Yes, pattern or
pattern.
architecture, whatever you want to call it, pattern. So now come on, Pratina, answer. What is the pattern that you are seeing? What's the pattern? Is there a problem about it? You know that
ma'am,
this
I
is,
don't
huh? You don't know the pattern?
don't know, ma'am.
This is the abnormality, right? All,
Yes, ma'am.
yeah. So now tell me the pattern. What's the
Solid
pattern?
zone pattern, zonation.
Zone pattern? No, I don't think that's the zone pattern. Come on, Adil, help her out.
Uh, the abnormality is in
Diffuse.
diffuse sheet.
Diffuse.
Diffuse.
Diffuse sheets.
It's in sheets.
Excellent. Adil, what's the definition of sheet? When do you call something a sheet?
When they are arranged in a monolayered and in a uniform plane.
In other words, a sheet is something that is patternless, no?
Patternless.
Otherwise you have nests and you have cords and you have trabeculae and you have clusters and you have sheaths and you have fascicles, all of them palisades. These are all patterns, right? When you don't have that, you call it a
Diffuse sheets.
Sheets.
exactly.
Diffuse.
So now, Krutina, you know what is the pattern? What is it? Krutina, you disappear. Are you there?
Yes.
Yes. So
Yes,
what
ma'am.
is the pattern?
Diffuse, ma'am.
Diffuse sheet-like pattern.
Diffuse sheet like.
Yes, you don't have to just, sort of say what I say. Do you agree that this is a diffuse sheet?
Yes,
Yes?
ma'am.
Or you don't agree, Rutina? Rutina, are you there?
Yes, ma'am.
So
Yes, ma'am.
do you agree that it is a sheet?
No, ma'am. It is a diffuse pattern.
So diffuse and sheet is different, Rutina?
No, ma'am. Same.
Adil, will you explain to her what you said?
As there is no definite pattern, the abnormality is present here in a patternless pattern and a diffuse sheet.
So diffuse,
Patternless.
a
It is
sheet is always diffuse.
Yes.
That's what you have to understand, all right? So when you have a solid tumor that is growing in a patternless way, it is going to be a sheet, and a sheet in a solid tumor is diffuse. Okay? You may use diffuse, say, if there is an infiltration. all right, and you say there is a diffuse infiltration of some part. It means that that infiltration is not focal, it's everywhere. It may not be a sheet-like infiltration. There may be cords that are going here and there, but it is diffusely infiltrated. Krutina, do you understand what we are saying? The
Yes, ma'am.
difference between that what every sheet is diffuse, but all diffuse things are not necessarily sheet-like. I hope all of you understand this, yeah? So this is a diffuse sheet-like pattern. All right. Now we come to Annapurna. Will you tell me where I should put my high power? Do you want to go where the thyroid is, or do you want to go where the abnormality is?
Ma'am, it's where the abnormality is in
Where
the
the
junction.
abnormality is. Now here is where the abnormality is. Yes, I have
Yes, ma'am.
deliberately gone close, I mean, to where the thyroid and the abnormality are
In the
close
junction.
to one another. Yes, Krutina, come on, this is your case. What do you
Yes,
see?
ma'am. The smear show
This is not
thyroid
a smear,
follicles.
this is a section, Krutina.
Sections show
Yes.
thyroid follicles which is filled with the colloid-like consistency. There was a cholesterol cleft-like structure.
See, you know, Krutina, you jumped from the thyroid to the cholesterol cleft, right?
Yes,
Is there a more systematic way of describing this?
and there was a hypocellular area.
I think I've said this before, and I'll say it again because I doubt that Krutina has ever attended a a class, because you say you don't attend very many. That's all right. It's not a criticism. Yeah, but there is systematic way of doing everything. Yeah, and what is that systematic way, to make observations such that somebody who is not looking at the section, yeah, is still able to follow you as you are describing what you are seeing. And I often say that I have had more than 40 years of looking at slides. I'm reasonably competent, yeah, and I've seen many things. Now, if I lose my eyesight and I want Kruti to be my eyes, then she has to describe this such that I will see what she is seeing. And Krutina, by saying that I see some thyroid filled with follicles and I see cholesterol clefts, has not made me see what you are seeing in a systematic way. Do you get what I'm saying, Krutina?
Yes, ma'am.
Right. So now I have you to be my eyes. Now please describe what you are seeing in this section. Come on, Krutina.
Uh, I cannot appreciate properly.
You cannot appreciate properly. Come on,
No, ma'am.
Ranjani.
Sections show thyroid follicles of varying sizes, and there is a zone of pale eosinophilic uh, amorphous material, and beneath that there is a highly cellular area, and there is again a pale pale eosinophilic zone with some cleft-like spaces seen.
All right. If I was not looking at this slide, Ranjani, I would not know what you were saying. If I were describing this to you and you were not looking at the slide, I would say that at the periphery, yes, I am seeing thyroid tissue, all right, which is got whatever. Then deep to that thyroid tissue is this zone of, it is what you're saying is amorphous. It is not amorphous. This is something that is collagen, isn't it? It's like almost like a capsule of collagenized, thick collagenized tissue, which is deep to the thyroid. And even deeper to that is this very cellular tissue at the center of this lesion, you are seeing, that means deep to that, you are seeing a pale zone in which there are cholesterol clefts. So what am I seeing from the, you either describe from the periphery to the center or from the center to the periphery. Do you get my point, Krutina and Ranjani?
Yes,
Huh?
ma'am.
You can see layers over here, starting from the center, going more and more peripherally. There is almost like a zonation that is being seen. Am I making it up, Krutina
Yes, ma'am.
and or Ranjani? So
Yes,
what was the difficulty then in making this description? Was there a difficulty? No, the answer is that we have never tried to be systematic in the way that we make our observations. So you need to practice a system. Okay, you get the point,
yes, ma'am.
Tina?
Yes.
Yes. Annapurna, does that make sense to you?
Yes, ma'am.
Yes. Adil?
Yes, ma'am.
Are you going to do it or you're just going to listen, go back and start your higgledy-piggledy way all over again? I hope you don't do it in a higgledy-piggledy fashion because you lose out. All right.
Yes.
Now, yes, Krutina, now. Description.
And from normal thyroid follicles filled with the colloid.
Yeah, we don't need to do that again. No, we know that it's there. Very good. Now, come on. What is happening? We are now
Ma'am,
going from the periphery towards the center. So now tell me,
yes,
what
ma'am.
are you seeing?
Ma'am, the section shows a spindle shape or fibroblastic like cells.
Yes.
Uh,
Yes, very good.
and there was a chronic inflammatory cells.
Infiltrate. Everybody looks for chronic inflammatory cell infiltrates. Now, just describe what you're seeing in this very cellular area.
Yes, ma'am.
What are you seeing? You told me there are spindle cells. That's all
Spindle cells.
I heard, and I heard that there are fibroblasts. Okay, that's an
Yes, fine.
interpretation. Can you describe anything more? What is the way in which these are growing? These spindle cells? In which way are they proliferating?
Diffusely.
Diffusely. Is that all that you see? Diffuse means what? Huh? What does diffuse mean?
And ma'am, there was some hypocellular area and uh, below that hypercellular area.
Ranjani, what do you want to say? Is there any pattern to be seen here? No, right?
Oh, ma'am.
Yes. So what do you call that? Yes, we said sheets, but there is a word for it when spindle cells grow in without a pattern. What is that word that we use when spindle cells, and you can see that they are spindle at this part, you can only see that they are spindly. What do you say when spindle cells don't grow in fascicles, they don't grow in sheaths, they don't grow in interwoven herringbone patterns, they are not in any pattern? What is that word that we use? Come on, Ranjani, Annapurna.
Like haphazard arrange.
Haphazard.
Haphazard arrangement. Yes, so they are patternless, haphazardly arranged spindle cells. Yes, now isn't that I keep telling you people that words have a meaning. Words trigger thoughts. Yes, just saying spindle cells and I see some fire. It doesn't help you. If you use the appropriate word in your head, in your description, it will trigger a thought. Okay, so hold that thought. These are spindle cells, and there is a fibroblastic stroma. You can see that because it's rear. This is at the periphery of the there is the thyroid, then you can see this collagenous stroma, and you can see haphazardly placed spindle cells. Very good. Now, Krutina, we've gone from the periphery towards the center. And what do you see here?
Section show hypocellular and hypercellular area. In hypocellular area, cholesterol clefts are seen. Surrounding the cholesterol cleft, some inflammatory cells are seen.
Right.
And
so towards the right of the section is the hypocellular area.
Hypocellular area.
Yeah.
And
And
on the
what
left,
does it contain?
it contains lymphocytes.
Lymphocytes. What is the major content that you see in this area? What is the major content that is there? Neutrophils.
Ma'am, I cannot appreciate properly.
Really?
It's a pink amorphous material.
Who said that?
Me.
Annapurna said pink amorphous material.
Material.
You know, every time that Krutina says, I cannot appreciate, Krutina, you are trying to look at the cells. There is a lot more to see to what you are looking at than cells. You do not see this amorphous material, granular amorphous pink material. Okay? And from this granular pink amorphous material is coming is all these cholesterol clefts are related to this granular pink amorphous material. Do you agree or don't you agree, Krutina?
Yes.
Do you agree, Krutina, or you don't agree?
Yes, ma'am, agree.
Don't say yes, ma'am, you agree unless you absolutely agree. If you don't agree, you better say it now. Do you
No,
agree?
ma'am. Agree, ma'am.
You agree. All right. So we see this granular pinkish material, which is, yes, amorphous. And you are seeing all these cholesterol clefts. And yes, you see some things and you can't appreciate, all right. There may be a neutrophil, there may be some apoptotic cells, there may be many things. And also in the cellular area, this is a very circumscribed area, and then you have the cellular haphazard spindle cell proliferation, and you see some cholesterol clefts that are seen within this. You see
Foreign body type of giant
Foreign
cell. Foreign body type of giant cell.
Exactly. Do you see anything else? Oh, you see foam cells. Can you see foam cells?
Yes, ma'am.
Plenty of them
Plenty.
are seen over there. Very
Yes,
good.
ma'am.
Right. So now, come on. What kind of cells are you seeing here? Are they all spindle shaped, Krutina?
Yes, ma'am. Spindle cells, fibroblastic cells, and foreign body type of giant cells.
What is the difference between a spindle cell and a fibroblastic cell, Krutina? What? What is the difference? Are fibroblastic cells spindle cells?
Yes, ma'am.
Yes, ma'am. And all spindle cells are fibroblastic? You understood my question?
Yes, ma'am.
Every spindle cell in the body that you see, is it fibroblastic?
No, ma'am.
No, ma'am. So when you say I see spindle cells and fibroblastic cells, then I assume that some of the cells that you're seeing are fibroblastic and the others are not. So is that what you mean, Krutina? No, I don't think
no,
that's
ma'am.
what you mean. And I can see more than spindle cells. Can anybody see anything else that is not spindle over here?
Epithelioid type of
Epithelioid cells.
Epithelioid type of cell.
Epithelioid cells. What are these epithelioid cells? Will somebody please annotate it for me, because I can't see an epithelioid cell. Yeah, come on, who wants to annotate? Adil, you said epithelioid in a loud voice. Come on, ask for annotation.
Yes, ma'am.
Okay, Sai. Come on, Ranjani.
Yes, ma'am.
Come on, where are your epithelioid cells? You marked it somewhere?
I have marked, ma'am.
You have marked where? Oh, there. That's an epithelioid cell.
Ma'am,
Why did you say it was epithelioid? Epithelioid. You're looking here and there and you're calling them epithelioid. Let me just get rid of it and then let's see the cells.
there are occasional
Huh? Occasional. Acha.
scattered. I mean,
But
scattered.
they're not epithelial cells. What you see are big cells, yes, with nucleoli. Of course, I saw them.
Histios.
But what do you think they are?
They are histiocytes.
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 Epithelial. They are endothelial cells and they are very plump. Okay, so yes, there are spindle cells. There are stellate cells. There are so many stellate cells. You can't see the processes of the stellate cells. Of course, there are spindle cells, and look at the processes of some of these stellate cells. Oh, look at them. They're long stellate cells. Then you see these plump endothelial cells. And what do you see here? What is this?
Ex extravasated RBCs.
RBCs.
Extravasated RBCs. Lovely. So now, Rutina, can you
Yes.
please tell me what you have seen? I think we have just one high power view, and there are no epithelial cells. Look at the spindle cells, yes, and you can
Yes,
see
ma'am.
stellate cells, or you can't see stellate cells. Look at these cells with the processes. Oh, look at them, so many
Yes, ma'am.
cells with processes. So there are spindle cells. I agree, there are more spindle cells than stellate cells. Okay, and these are all haphazardly placed. Here are the very plump endothelial cells. Okay, there are lots, and they have nucleoli, and so also do the cells with the stellate cytoplasm. Okay, so now come on, in one sentence, please tell me, what have we seen, Krutina?
Yeah. Section show thyroid follicles with filled with the colloid-like structures, and then there is hypocellular and hypercellular area. Hypocellular area is filled with the pink amorphous material, and cholesterol clefts are seen. Foreign body type of multinucleated giant cells, spindle cells, spindle stellate cells type of cells are seen.
Krutina, bad. Okay, come on, somebody else, Ranjani.
Section show uh, from the periphery to the center of thyroid follicles of varying sizes
Very
and
good.
and underlying fibrous tissue and underlying hypercellular areas, and that is centrally leading to a pink amorphous material where cholesterol clefts are seen. And these
Excellent.
cholesterol clefts are seen coming from the central area towards the hypercellular areas, and
Okay.
these cholesterol clefts are surrounded by foreign body type of giant cells, and there are plenty of plump endothelial cells along with stellate cells, and extravasated RBCs are seen.
Yes, what, come on now, anybody else, Annapurna? You want to improve on this description?
Yes, ma'am. Section shows normal thyroid parenchyma with spindle cell circumscribed lesion comprising of haphazardly arranged spindle cells. On high part, these spindle cells are stellate cells with plump endothelium and extravasated RBCs. The central necrotic area with cholesterol clefts are noted.
Okay, Adil, anything more you want to add? Because Annapurna said the right word. There is a haphazard proliferation of spindle cells that surround an area which, yes, is amorphous. It may be necrotic. I don't believe it is necrotic. It is a granular material with cholesterol clefts. There is no necrosis, Annapurna. Let me tell you that. It is not necrotic. And we'll come to what it is in a second. But the word was this spindle cell proliferation is very cellular, okay? But it is completely haphazard. And it has these extravasated RBCs. There is collagen that is being formed by this. And there is a zone at the periphery between it and the thyroid, which is beautifully collagenized. Did you notice that?
Yes.
Yes. And so there is a zonation. There is a zonation. There is this haphazard arrangement. There are extravasated RBCs, plump endothelial cells or no plump endothelial cells. They were there because you pointed them out. They were not particularly, prominent. And you had that central area which was pink, light pink and granular, from where cholesterol clefts seem to be emerging. All right. So now, what is this lesion? Come on, Krutina, because you're the one. See, here are your observations, which we just said. Lesion clearly within the thyroid gland, well demarcated, not encapsulated. Central area of necrosis with cholesterol. I've said necrosis, but it is not necrosis, okay? Foreign body giant cells phagocytosing this cholesterol clefts. Okay, now if somebody wants to ask, what is the overall appearance of this lesion? What would you choose? I think everybody would choose just one. What is that?
Mesenchymal.
Mesenchymal. Excellent. Yes, I don't think there would be any other thing. Now, do you think it's neoplastic or non-neoplastic? It is obviously pathological. Yes. Is it neoplastic or non-neoplastic, Krutina?
It is a neoplastic.
You think it is neoplastic. Adil?
Non-neoplastic.
Non-neoplastic. Annapurna?
Non-neoplastic.
Non-neoplastic. And Ranjani?
Non-neoplastic.
Non-neoplastic. So now, Krutina, why did you think it was neoplastic? Why did you think it was neoplastic? And then I will ask.
Sorry, ma'am. Non-neoplastic.
Non-neoplastic. Acha, now you've changed your mind. What are they saying in the chat box, Poonam?
Non-neoplastic, and one has answered previous procedure related changes.
Yes. So it is non-neoplastic. Absolutely. If it is neoplastic, you have to answer, no? Is it anaplastic carcinoma? Is it sarcoma, spindle cell thymoma, fibrous histiocytoma? Of course, it is none of the above. It is not neoplastic. Okay. So if it is non-neoplastic, what is it? Come on, Rutina.
Ma'am, it may be the post-operatively or post-FNSE.
Okay, so where does it fall in one of these non-neoplastic things? Why is it not neoplastic? Well, obviously the cells are spindles, stellate, fibroblasts, myofibroblasts. All right. There is evidence there of something that has happened before, because there is an area. Okay. And what do you think that area would be?
FNSE tract.
FNSE.
Yes, and this
FNSE tract.
So it is
reparative
regeneration, healing, and fibrosis. Okay, and the final diagnosis is a reparative myofibroblastic proliferation around an area of hemorrhage within the thyroid gland. That's why there are so many cholesterol clefts. Where does that cholesterol come from, Krutina?
Pink amorphous material.
Where does it come from? Why are there cholesterol clefts? Why? What is that pink amorphous material? Huh? What is it? What is that pink amorphous material? Anybody? Annapurna?
Ma'am, those cholesterol clefts because of cell membrane, ma'am.
Cell membranes, yes. Or hemorrhage, no? There is so much cholesterol in the plasma. You think that you can have plasma without any cholesterol at all?
No.
Huh? No, even if you take buckets of statins, you are still going to have cholesterol in your plasma. So whenever there is hemorrhage, it is very likely that you are going to get cholesterol clefts. Okay, this is fundamental. Go and read your Robbins, find out why you get cholesterol clefts. Okay, so it's reparative myofibroblastic proliferation and organizing hemorrhage within the thyroid gland. And organization means, what does it mean, Rutina? What's the meaning of organization? What is, do you ever use this term? Have you ever heard it being used? Rutina?
No, ma'am.
No, ma'am. Anybody has heard this word organization being used? Ranjani?
Organizing thrombus.
We talk about an organizing abscess. We talk about organizing
Organizing
pneumonia. We talk
thrombus.
about
Organizing
organizing
thrombus.
thrombus. Excellent. So what does this word organization mean?
Reparative
Anybody?
change.
Adil?
Containing the pathology and resolving it.
So it is resolution or repair that involves the connective tissues. Okay? You can't have organization of an epithelium. That is regeneration of an epithelium, whether it is a gland or it is squamous epithelium. You don't talk about organizing squamous epithelium, but we talk about organization when it affects connective tissue. Okay, so organizing abscess, organizing thrombus, so when the connective tissue is involved in repair and healing and fibrosis, we talk about organization. Have you understood that, Prutina? Yes. So we have got an organizing hemorrhage, and you know what the real word, if you go back and you look at this thing, sorry, and you look at those, if you had this without the cholesterol clefts, without the rest of this, the organizing, you saw the hemorrhagic bit and it was not in the thyroid, you know what this would look like with all this extravasated blood and haphazard proliferation? Where have you heard that description before? Haphazard extravasated RBCs. Come on, Adil.
Nodular fasciitis.
Nodular fasciitis. And this is what I want you people to understand, that nodular fasciitis resembles a healing process, except that in nodular fasciitis, we don't know what the stimulus to that healing is. And nowadays, we believe, if you read the new textbooks, you read the WHO, that nodular fasciitis has got an molecular abnormality. Okay, so just because it has a molecular abnormality doesn't mean that it is a tumor, but they are beginning to call nodular fasciitis a quasi-tumor. But otherwise, your normal healing process, look at it. Here it is. Does anybody believe that this is nodular fasciitis? Adil, you believe that this is nodular fasciitis?
No, ma'am.
No. There is a reason why we have this kind of process over here. Haphazard proliferation of spindle cells and myofibroblasts, extravasated RBCs. The word haphazard. Okay, if you didn't find the stimulus for this, somebody might want to call this nodular fasciitis within the thyroid gland. I think it would be a little silly, but nonetheless, this is what nodular fasciitis looks like, okay? Like a repairing inflammation, like an organizing wound, anything. If anybody has seen a breast from which a lumpectomy has been done, and you see that lumpectomy after the mastectomy comes out 6 weeks later, it looks exactly the same. And if you study that, you will know what nodular fasciitis would look like. Is that clear now to everybody?
Yes,
Yes,
ma'am.
ma'am.
Yes. So there are many parallels that you could actually get from understanding biological processes. All right. Now, case number 3. Chalo. we are running short of time. So who comes next? Ranjani, come on.
Yes, ma'am. 59-year-old male,
Hmm.
open biopsy of a lytic lesion in the distal end of right ulna is taken, ma'am.
Excellent. All right, very good. Come on now.
Uh,
Nobody should ever read or report on a histology of the bone without looking at the bone pictures. Okay. Now,
the left side image shows an X-ray of um,
what
X-ray
part of the
X-ray of
body?
hand, ma'am. X-ray of hand showing wrist joint.
Very good.
And there is a
You need an arrow or something? Should I give you a...
annotation.
Yes, okay, good. Come on.
There is a lytic lesion with a sclerotic rim, and there is a soft tissue lesions seen.
Okay. All right. That's on the left side. No, that's a plain X-ray.
Yes.
What's the right side?
It is a CT.
No, it's not a CT, Ranjani.
MRI.
See the two words over there, spin and tilt?
Yes, ma'am.
MRI.
MRI, ma'am.
It's an MR. Very good. It's an MR. Okay. So does everybody agree with Ranjani that there is a eccentric destruction of which bone is that?
The distal end of ulna.
Distal end of the ulna. Is that the only thing that one sees there?
No, ma'am.
No.
There is a destructive lesion at the base of fifth
Yes.
metacarpal.
Yes.
Ma'am.
Metacarpal.
Yes, it is. There is something else at the fifth yes, at the metacarpal. Yeah, and also look at this. Then the carpal bones are also have been destroyed. So there is a destruction of the carpal bones, the ulnar, the distal end of the ulnar, and as well as the fifth metacarpal. Yeah. So there is a huge destructive lesion that is going on. Very good, Ranjani. Now, sorry, we went a little ahead. Okay, come on. Now what do you see, Ranjani?
Section show a destructive lesion.
A destructive lesion.
Sections show
that it is a destructive lesion. No, what are you seeing? What is being destroyed? How can you say there's a destructive lesion unless you tell me what's being destroyed?
I mean to say the sections studied from the destructive lesion.
All right, good. Good, Ranjani. Yes?
Sections studied from the destructive lesion show predominantly amorphous eosinophilic areas and few chondromyxoid and osteoid areas seen in this low power view.
So you said that there was amorphous material, right?
Yes, ma'am.
Right. Excellent. All right. You want to describe that a little bit further?
Which is arranged in the form of lobules, ma'am.
Yes, they're not lobules, but what they are is little nodular, or if you want to use the word floccular. The real word to be used over here is floccular. You know what is a flocculum? Do you remember anything in chemistry that we used to be taught when we were in, you probably did it when you were in your 12th or whatever standard. We never had 12 standards, yeah. We went to college and we learnt about floccular. That means out of a fluid, when something like a gel precipitates. Very good. Yes, Annapurna. That is a flocculum. So this is an acellular. Yeah, you want to use that word, right? It is an acellular you see them, they're all very well defined groups. I mean, it's not a group, it is a flocculum that is well defined and they are coalescing to one another. Yes, and you are seeing cartilage. Very good. Excellent. Now, what else are you seeing? Same thing, no? At higher power?
Yes, ma'am.
Okay.
And
You're also seeing
os
something
Osteoid.
osteoid. I'm not sure about osteoid, but I'm seeing calcification. At the periphery of some of these floccular deposits, there is calcification. Can you see it?
yes, ma'am.
Good. Look at the calcification. It's there at high power.
Yes, ma'am.
Okay. Now what do you see? What do you see? Ranjani, what
Yes,
is
ma'am.
this huge, big, pink thing that you're seeing here? What is this? This whole big, pink thing. What is it?
It may be.
Sorry? What is it? Can you see?
Yes, ma'am.
Oh, yeah. So what is it? Can all of you see?
Yes, ma'am.
All right. So what is it?
So,
This is
Collagenous tissue.
it's collagenous tissue.
Tissue.
Yes, good. So what is this collagenous tissue? Adil?
Yes, ma'am.
What is it?
The fibrocollagenous tissue.
Fibrocollagenous, what does that mean? Is it cellular or acellular?
Acellular,
Acellular.
hypocellular.
Fine. Where do you think this is? Where is this material come from? It was there in the history, right? So what is it? Huh? Yes? From where? And we saw the x-rays. So where does it come from? From close to the wrist joint, right?
Synovium.
So you think the synovium is collagenous?
No.
No. So what is
Articular
collagenous?
cartilage.
Articular cartilage is collagenous. Now that's news to me. Who said that? Please think before you speak. Huh? What can be collagenous around a joint?
Capsule.
So there is
Joint
a
capsule.
joint capsule, right? So you've got ligaments, you've got joint capsule. There are so many things around a joint, and that is exactly what this looks like. Okay, so this is not something that is pathological. This is, if you were talking about destructive or infiltrative, this is infiltrating the joint capsule and the ligaments around the joint. Yes, and you see this grayish, very well defined acellular, extracellular material, which is surrounded by what? What is it surrounded by? Yes? What is it surrounded by? Ranjani, you can see it here.
It is surrounded by
What?
fibroblasts and
Fibroblasts. You think these are fibroblasts?
no, ma'am. These
And what are these things, these big cells?
Osteoclast type of
type of
cells.
Osteoclastic giant cells. You think they're all osteoclastic giant cells? Or they could be foreign body
giant
Foreign
cells.
body.
so they are foreign body
Body
giant
giant
cells.
cells.
Yes.
And macrophages.
And all these are macrophages. Yes, they are palisaded histiocytes. You can see them palisading. What is a palisade?
Fencing.
Yes, what is a
Rimmed
palisade,
by.
Ranjani?
When
Yes,
these
what is a palisade?
they are rimmed by something.
No,
When it
palisading is not about rimming. What is a palisade?
Parallel arrangement.
arranged.
A parallelly arranged structure or a parallelly arranged row of cells where the length of the cell is perpendicular to the direction in which that row is proceeding. So all of these histiocytes are arranged like this. I don't know, each time I draw the palisade, okay? You see these histiocytes that are like this, like this, like this, like this. They're all parallel to one another. That's the length of the cell. And you have, this is the direction in which this thing is going. Can you see that? You can see this, yes? And you can see these parallelly arranged cells. That is what is a palisade. Do you get it?
Yes, ma'am.
Yes, ma'am.
Yes. So there is a palisade of histiocytes around this, these deposits. Shabira, please don't ask for annotation if you don't mind, okay? Because I'm not going to approve it. And then you have calcification within these structures, okay?
Yes,
Of course, you've got some osteoclastic giant cells, but you've got a lot of foreign body giant cells as well. Now look at this calcification. Yeah? It's very peculiar, no? Look at this calcification.
Crystalloid.
Yes, there is a crystalline.
Crystalloid.
There are some crystals that are actually calcifying over here. You can see that because they are very spiky in nature. Now you can see, look at this palisaded, histiocyte. You've got some osteoclastic giant cells, yeah, and foreign body type giant cells. Now here is where you saw mixochondroid. No, what is this?
yes.
What would you call this, Ranjani?
It's woven bone, ma'am.
Yes, this is not quite woven bone. Yes, perhaps it is some reparative woven bone. There is cartilage, and you can see the destruction of cartilage by these floccular deposits, no? It is destroying this bone. So what do you think it is, Ranjani?
It can be a gouty arthritis, ma'am.
Come on. Is it congenital or acquired? Ranjani? Congenital or acquired?
It's a congenital one.
Is it congenital or acquired?
Acquired.
It can be acquired.
It is acquired.
It can be congenital. Acha?
Yes.
So is it physiological or pathological?
Pathological.
Pathological. Okay. What is it? Neoplastic or non-neoplastic?
Non-neoplastic, ma'am.
Non-neoplastic. Yes, I think it's very obviously non-neoplastic. So now come on. You have to choose from the chapters in Robbins. So which one will you choose, Ranjani? Cell injury, cell death, adaptations, acute and chronic inflammation, repair,
Acute and chronic
vascular
inflammation.
disorders. Come on, Ranjani, which one?
Acute and chronic inflammation.
She thinks it's acute and chronic inflammation. Okay. Very good. Krutina?
Acute and
Krutina?
chronic. Acute and chronic inflammation, maybe.
Okay.
Ma'am, I want to go with metabolic disease also.
Who is that? Who
Myself.
wants to go with metabolic disease?
Myself. Ma'am.
Ranjani?
Yes, ma'am.
Okay. Annapurna? What do you want to go with? Are you there, Annapurna? She's dropped out. Adil?
Yes, ma'am.
Yes.
Metabolic disease.
Metabolic disease. Yes. What are they saying in the chat box? Puna?
One has answered metabolic.
Hmm?
Rest have just answered non-neoplastic. Some more are answering metabolic.
Oh, yes. So this is metabolic disease. So which metabolic disease, Ranjani?
Urine metabolism, ma'am.
Urate metabolism.
Urine
Urine metabolism. Acha, okay.
Yeah, urine metabolism.
So now this patient didn't only have it in his there. You can see a big, what is this thing called?
Tofu.
Yes, it's a tofu. Yes, so this is gout. You can see that even in the large joint that there are these deposits, okay? And this is a destructive crystalline arthropathy. You know, even if you don't know that it is gout, this is a diagnosis that you can make. You know it is crystalline, it is an arthropathy. You saw the way that it was, these deposits were there in the joint capsule within the cartilage, and it was destructive. And we've said all this. These deposits were non-birefringent, okay? So there might be crystals over there, but they're non-birefringent because the crystals usually get washed out during processing, yeah? And there is this whole lot of crystalline arthropathy. It's usually secondary to a metabolic or an endocrine disorder. It depends on whether one has an enzymatic tendency to these deposits or otherwise. Yes, sometimes it can be precipitated by a variety of different endocrinopathies. And imaging has a very crucial role. Okay, I'm not going to go into this. There are so many of these crystals, you can go and look it up. But there is a very nice way of showing gout, and this is dual energy CT, right? And it picks up gouty tophi. That means it picks up urates when they are deposited over there. And you can, of course, the radiologist can give whatever colors they like, but in this case, it's the green stuff that is gout. It's called dual energy CT scanning. And you can see that it was there in the knee, it was in the foot, it was also in the wrist joint. So very good. So we've seen a metabolic disorder, and that is gout. Now we come to this last case. And who's going to take the last case now? Annapurna, or have you done it? Or Adil? Okay, Adil did the first one. Now his turn has come again. Come on, Adil.
62-year-old male, pain in the left knee while walking. Needle core biopsy was done. Following the diagnosis, the lower end of the femur had an en bloc resection.
Very good. So come on, look at this X-ray and describe it.
X-ray on the left side image show eccentric expansile hypodense area, hypodense lesion.
Is that what we call them? Do we call them hypodense?
Lytic.
When you look at an X-ray, what do you call it?
Radiolucent.
Yes.
Lytic.
Lytic
lesion.
Hypodense. Yes, come on. So lytic lesion. Yes.
And on the right side, the arrow showing break in the continuity, fracture is there.
It's a fracture. Yes, okay, there may be a fracture. Good. But you haven't described this adequately. You just said there was a lytic lesion. Where is this lytic lesion, and what does
centrically
the
placed in the metaphyseal region.
It's in the metaphyseal lesion. Okay.
It is
Anybody disagrees with him?
It is a epiphyseal lesion, ma'am, in the lower end of femur.
Yes, so it is epiphyseal. How do we know that it is epiphyseal? Is this a mature skeleton, or is it an immature skeleton?
Mature one.
Mature, all right. So in a mature skeleton, how do you know where the epiphysis is? You can see a line, no? See how beautifully you see this line? So you can see the line very clearly. Let's go up. Yes, let me annotate this. You see this line?
Yes, ma'am.
That's the epiphyseal line. Here also you see there is a line. And where is this lesion, Adil? This lesion is below this line.
And above also.
And above the line. Yes. So
it's
you have got an metaphyseal or a meta-epiphyseal lesion.
Yes.
Okay. So there is no doubt that it is epiphyseal. It is also extending into the
metaphysis.
Yes. Okay. Good. Now, so we got the arm block resection, and you can see this. See this
the,
lesion. Yes, now describe this.
the gross specimen is showing a cystic areas having which is filled with hemorrhage.
Yes.
And the overall architecture is maintained and
So
ma'am,
it doesn't seem to, there is maybe a slight crack over there that is very difficult to say on gross.
yes ma'am.
But the lesion reaches where? Can you
The,
see that here is the articular cartilage?
yes ma'am.
Yes, ma'am.
The
The
lesion is
lesion reaches right up to the articular
Articular
cartilage. So it
cartilage.
has to be in the epiphysis, no? Because the epiphysis is the epiphysis is that region extending from the articular cartilage to the epiphyseal line. Okay, so this lesion is very definitely in the epiphysis. All right, come on now. You saw these things. Adil, quickly.
HNE stain section examined shows a mm, c- mm, shows the periphery showing the cartilage
What cartilage is it, Adil?
shows the hyaline cartilage.
Hyaline cartilage.
Yes, I know it is hyaline cartilage, but of what site? What hyaline cartilage is this? It's
Articular
of the
cartilage.
it is of the
Articular
it's
cartilage.
the articular
Articular
cartilage.
cartilage.
Yes, Adil. Very good. It is the articular cartilage.
Articular
Now
cartilage,
tell me, what do you see?
which is unremarkable, and underlying surface shows cystic spaces filled with hemorrhage and lamellar bony trabeculae, in between which there is
Do you want to show
chondrocytes.
me where the lamellar bone is? Can you ask to annotate, please?
Yes, ma'am.
Yes, come on. Show me where is this lamellar bone? All right. He's drawn a black line over there. Yeah, everybody can see this black line.
Yes, ma'am.
Very good. Annapurna, do you agree that that is lamellar bone?
No, ma'am.
No, ma'am. All right. The next person, Krutina, do you think that that is lamellar bone?
Mm, don't know,
Who has
ma'am.
drawn the green line or the khaki line? Who drew that? Adil, did you draw that khaki line?
Yes, ma'am. Yes, ma'am.
Okay, you drew it. Do you agree, Annapurna, that that is lamellar bone?
No, ma'am.
No, ma'am. Krutina, do you think it's lamellar bone?
Don't know, ma'am.
You don't know. Ranjani?
I think so, ma'am. I think it is lamellar bone.
No. Lamellar bone is normal bone. Okay. And in this section, there may be a bit of lamellar bone that is forming from cartilage. Okay. But this is not what lamellar bone is. This is lamellar bone is normal bone. Why is it called lamellar bone? What
Because
is
Because
this
the
word?
collagen, the fibers are arranged in a parallel pattern, ma'am. Whereas in
Yes. So it's
oval, it is
either
haphazard.
concentric
either
or
concentric or
parallel. This is just bone. Much of it is woven bone
yes,
that is being formed. So please, Adil and everybody else who is listening, this is not what Adil has shown is not lamellar bone. Okay, you got it, Adil?
yes, ma'am.
Yes. So what is it actually? Is it bone, or what
Uh,
else could it be? It maybe some of it is woven bone, but what do you think it is?
it could be endochondral ossification.
Now, Adil, you're just digging a hole, okay, for yourself. What are all these pink things, Adil,
Ma'am,
that you're
could it
seeing?
be a cartilage?
Could it be cartilage? Who's saying could it be cartilage?
Oven bone, osteoid.
Annapurna?
Yes, ma'am.
No. What do you think this pink stuff is, Annapurna? There's a lot of pink stuff, right?
Yes, ma'am.
So what is pink stuff? Osteoid. So when
Osteoid.
osteoid becomes blue, what do you call it?
Calcification.
Calcified osteoid.
Calcification.
Now was that very difficult, Adil? The answer is
Calcium.
no. So the answer is that it is not difficult. This is calcified osteoid. Okay, now come on. What are you seeing now?
Uh,
Come on, yes.
HNES 10 section showing chondrocytic chondrocytes proliferation.
Chondrocytes. Okay. Why do you
Chondrocytes of
think these are chondrocytes?
ma'am, lacunae is there in which the chondrocytes are present, and many of them are
Chondrocytes are
arranged in
present in lacunae. Okay. You
many
mean
of
to say that
fine.
osteocytes don't sit in lacunae?
No, ma'am. Like many of them are in binucleated are
Many of
also.
them are binucleated. Very good. So here they are, right? Binucleated. And so therefore it is quite likely that they are chondrocytes. Yes. Okay. You see a lot of osteoid. Yes. Do you see osteoid?
Yes, ma'am.
Yes, yes, ma'am.
A lot of osteoid. And that osteoid is calcifying and
Calcified
possibly
osteoid.
even ossifying. Okay. Very good. Then what about the rest of what you're seeing? Have you described it? Is this
It
benign? Is this malignant? What?
some like
What?
again these calcified osteoid, and in between which the chondrocyte proliferation and areas of
Chondrocyte proliferation. What I see are cells with clearing in the cytoplasm, right? Yes. And a lot of matrix.
lot of
And that matrix is,
Clear cells.
there are clear cells,
Yes.
yes. And there is a matrix which is really not like hyaline cartilage. That matrix is very osteoid-like, yeah? So there is an osteoid-like matrix which is calcifying, and you have these clear-looking cells that are depositing that matrix. Look at it. Yes or no?
yes, ma'am.
Yeah.
Ma'am,
That's
can
right.
I annotate
Yes,
just
please, tell me.
ma'am, are these clear cells? Like I have encircled this.
Circle something. I can't see what you have encircled.
I'm changing the pen, ma'am. Actually.
Yeah, okay.
Like these clear cells.
Yes, they are clear. There are so many clear cells. Look at them.
Yes.
The
Yes.
nucleus is sitting in a halo.
Yes, ma'am.
Right. So there are lots and lots of clear cells that are present all over here. So there are clear cells. Yeah. Some of it looks as if things have fallen out of a hole, no, of a space. But there are clear cells without doubt. Some of them are eosinophilic, but there are very definite clear cells. Here is one clear cell. All right. You can see that. This one may not be so clear, but there are numerous clear cells over here. Here's a clear cell. Okay.
Ma'am, are these not chondrocytes? My doubt.
Yes. Because they're sitting in lacunae, they could very well be chondrocytes. And here, if you see, there is a very clear double. Can you see two nuclei inside that?
Binucleation.
Binucleation, yes. So you get the feeling that there is osteoid and calcifying osteoid, or a matrix that looks like osteoid, but the cells don't look like osteoblasts.
Yes,
They
yes.
are looking like
Chondroblast.
chondroblasts or chondrocytes. Very good. Excellent description. Okay. Oh, come on. You can see more of it at high power and is very obviously malignant. And you saw that binucleated cell sitting in lacunae.
Yes.
And what is this now?
Large areas of spaces filled with hemorrhage.
Yes.
And
So what do we call that?
Telangiectatic blood vessels.
Telangiectasia. Yes. It's telangiectasia when you think that something is an osteosarcoma. Otherwise we call it aneurysmally dilated vessels, right? all telangiectasia is an aneurysmally dilated vessel. Okay, and what else do you see besides the clear cells? And you see so many clear cells over here. What else? What are the other cells that you see?
Multinucleate giants.
Multinucleated osteoclasts. So what is your diagnosis, Adil? It's not difficult. What's the diagnosis? You have a radiolucency in the epimetaphysis, fairly well defined with a narrow zone of transmission. A transition actually looks benign. There is nothing in this X-ray that says that it is aggressive. There is some spotty sclerosis within the lesion, and we saw that sclerosis. It is calcification of an osteoid-like matrix. Okay, you see that that's where the lesion actually is. And when you look at the gross, it's an ill-defined lesion reaching up to the articular cartilage with multiple blood-filled spaces. So what's your diagnosis, Adil?
Telangiectatic osteosarcoma.
Telangiectatic osteosarcoma. All right. Anybody else?
Clear cell chondrosarcoma.
Who said that? Ranjani. Ah, clear. So there is another diagnosis. Clear cell chondrosarcoma. Any other diagnoses coming up in the chat box?
No, ma'am.
No. You've got a chondroid, myxochondroid matrix. You also have reams of calcified osteoid-like matrix, aneurysmally dilated spaces containing blood. Okay, and a typical radiology. Okay, there is only one diagnosis in this case. This was the biopsy that we got, which was much more myxochondroid. Yes, it is. You can see this. This is much more myxochondroid, and it's obviously malignant. Yes, so there was no question of this being a sarcoma. This is a clear cell sarcoma. It's a very uncommon tumor. You see it in adults in the 3rd to the 4th decade. And it may be mistaken on imaging for a chondroblastoma because it's a benign looking lesion. But when you stain this for S100, even if you don't stain it for S100, we don't need the S100 to make this diagnosis. Yeah, it is a clear cell chondrosarcoma. So Ranjani, that was a good diagnosis. Okay. And as I say, I don't want people to reach the right diagnosis. You have to get the right message. So what was the message you should get over here, Adil? The message?
A benign looking morphology on X-ray and also on gross, but histologically this is obviously malignant.
But it's not just about it being benign. It is in the
Epiphyte.
region, which is where you expect to see a chondroblastoma. And very rarely you will see an osteosarcoma. So when you are dying to make a diagnosis of an osteosarcoma in the epiphysis, think that maybe it is not an osteosarcoma, it is a chondroblastoma, which can mimic an osteosarcoma, or it is a clear cell chondrosarcoma. All right? Very good. Now, I have the last quiz, and I am not going. Yes, sorry, is there a question?
Yes, ma'am. Ma'am,
Yes,
Priyanka Bhanushali has asked how to differentiate between calcifying osteoid and woven bone.
Oh, you can't make that a woven bone. Ah, woven bone should actually have bone, no? So bone means that there is the laying down of a matrix which has calcium phosphate in it, okay? And in that it is laid down. Even woven bone has got certain lines in it. They're not lamellar. It is a higgledy-piggledy way of this. So if you are unsure, just put it under polarized light or even lower your condenser and you will see lines in woven bone which don't have the parallel lines of a lamellar bone, but they are there. And if you have a polarizing thing, it is so beautiful because the collagen which is being laid down, you know that osteoid is nothing but collagen, okay, which then gets calcified. So you'll see the lines that are seen over there. Who is this? Dr. Banushali. I just do that experiment under either just lower your condenser, or if you have a polarizer, then use the polarizer and you'll be able to see this. Okay, go and look at fractures that are healing, if you have got, or reparative bone that may be seen on the surface of, periostitis, and you'll know what woven bone is. All right, if there is if you send me an email, I will send you a picture of woven bone. Is that okay, Dr. Banushali? Say yes in the chat box. All right. Okay. Now, who's the next one on the scene? Annapurna. Come on. 28. This is a quiz. 28-year-old female with menstrual irregularities. The USG showed a uterine mass, and somebody very cleverly took a core biopsy under CT guidance. And I am not asking you to describe it. Okay? Just look at it, Annapurna, and everybody, and tell me what you think this is. Those who are looking at it at home can put it in the chat box. You guys, at the end of this, you guys meaning Annapurna, and I'll ask the other three what this is. And you must get this diagnosis because it is a spot diagnosis.
Adenomyosis.
Annapurna said adenomyosis. Yeah, Annapurna, you said adenomyosis? I'm disappointed. Adil, you've seen more than enough.
Ma'am, endometrial stromal.
All right, Adil says endometrial stromal tumor. Krutina?
Ma'am, endometrial adenocarcinoma.
Endometrial adenocarcinoma. Okay. Ranjani? What is it? What, Ranjani? I got Annapurna saying that this is adenomyosis. Adil saying that this is endometrial stromal tumor, he said. Krutina says that it is a carcinoma, which I suppose she says is infiltrating the endometrium. And now Ranjani. Come on, Ranjani. We have to now end it. What? I'm telling you it's a spot diagnosis. What is it? What's in the chat box? Anything in the chat box?
Yes, ma'am. Endometrial stromal nodule, followed by leiomyoma cellular. One has answered endometriosis.
Okay.
That's it, ma'am.
That's it. Okay. And Ranjani has no clue.
Yes.
Did anybody notice that there were arterioles
Yes, ma'am.
right throughout this tumor? Did you notice these? Huh? They are absolutely diagnostic of something that everywhere, arterioles, 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 in a very blue tumor, which is made up of short, spindly or oval cells with dense nuclei. Yeah, look at these arterioles. Yeah, and there's nothing else. There are no glands. Are these glands? No. Again, these are arterioles. Look at the very pink, smooth muscle in the walls. Everywhere. So now, Adil, what is this? What is it? Adil?
Yes, ma'am.
What is it?
Endometrial
It is endometrial, low-grade endometrial stromal
Stromal
sarcoma.
sarcoma.
This is absolutely diagnostic. Yeah. Punctuated by arterioles, resembling the spiral arterioles of the secretory phase endometrium. The M got lost. Okay. Yeah. This cannot be secretory phase. This cannot be adenomyosis. There is no endometrial gland that is to be seen. And then you saw this. You're seeing them insinuating and what we often talk about.
Tongue-shaped,
shape.
Ah,
tongue-shaped extensions.
what? Into the
Biometry.
lymphatics of the uterine wall. No, look at that. Krutina, this cannot be a carcinoma. They are all
Yes, ma'am.
short, spindly cells. They don't have an epithelioid appearance. And this is the last question I'm going to ask. What marker should not be expressed in a low-grade endometrial stromal sarcoma? Come on, Adil, you made this diagnosis.
Cyclin D1.
Cyclin D1. He's absolutely right. You can get SMA sometimes. You always get CD10. And of course, you can get ER or PR. Yes, but you don't get cyclin D1. If you get cyclin D1, then this is a high grade sarcoma. Okay, and it will not look like this with all the arterioles. Here is CD10. You can see that. Right? Here is the SMA where you see the arterioles. You can see the thick muscle wall of an arteriole. It's too late for me to ask you what an arteriole is and why it has a muscular wall. If anybody's interested, you should go and look at it. Okay, and here is Desmond. You can see it's negative in the tumor. The uterine muscle has expressed it. And what is this? This is ER. You can see that it is a nuclear stain and it is diffusely positive, and you have the negative control, which are these vessels. Okay, so it's worked well. Cyclin D1 should never be present. What are these? What is cyclin D1 marking over here, Adil? It is positive. You can see that there is something, but what is it marking? And this is what we look for in any cyclin D1 immunohistochemical stain. It is an internal control. So what is it? Come on, Adil. What does it look like to you? Anybody? Anybody in the chat box?
Not yet, ma'am.
What? It is
Lymphocytes.
endothelial cells. Okay, the endothelial cells of all blood vessels will express cyclin D1, and that's an internal control. Excellent. So now I have ended. This is thanks from me and from, who's this guy? Annapurna? Who's this guy?
One
Who's
is
this guy?
carpenter.
Oh, I know that one is a carpenter, but who's this guy?
Walrus.
He's the walrus, yes, because he has a
Walrus.
mustache. And people who have those bushy mustaches are known, those mustaches are known as the walrus mustache. Okay? Who's this guy?
Carpenter.
He's the carpenter. And you see his saw and all his tools over there? Yes. Okay. So thank you very much from me
Thank you, ma'am.
and from the walrus and the carpenter. Thank you. No, thank all of you because you have been very good, all four of you. You have answered questions and you have been unafraid or uninhibited to put yourselves on the line, and that's the only way that you will learn. Okay, thank you very much. I will end now.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
I will stop sharing my screen. Okay. So,
Thank you, ma'am.
not at all. I hope you learned a few new things today. Yes?
Yes,
Good. So there are no, I hope there are no questions. I'm sure there are no questions.
No, ma'am. Ma'am, thank you for providing new insights into the approach to diagnosis of histopathology as well as cytopathology, as you always do. And ma'am, many of the attendees have thanked you for this session. I also thank the participants for their active participation. Before we end the talk, a brief about the next upcoming lecture. That is on 4th October, or that is Tuesday. There is a talk on normal histology